Letting go of every single dream, I lay drawn down at your feet. Every moment of my wandering never changes what you see. I try to win this war, I confess. My hands are weary, I need your I will trust in you.
I'm Good morning. Good morning, everyone.
Good morning.
Thank you, Daktari.
You're muted.
No, they are complete. Okay. We are just waiting for a few people, then we can start the session of today. I think we can start is exactly 9:10 in Kenya. And I would like to welcome everybody to today's session. It's a very critical session based on what we discussed yesterday. We are continuing with yesterday's program that we were not able to complete. And before we start, I would like to request one of our team members, Bishop, to start us with a word of prayer.
Francis, if the bishop could send us a message so that we can be able to give him the rights. His name.
Thank you, Edwin. Please, Bishop.
Edwin, if you could kindly unmute, I think it should be Pastor Susan. She's requesting that you unmute her, Susan Wanjiro.
Muted her.
Thank you. Good morning, everybody. I would like us to pray, and as we pray, let us meditate on Colossians 3:23 and 24. The Bible says, "And whatsoever you do, do it heartily, as unto the Lord, and not unto men, knowing that the Lord, knowing that you shall receive a reward from the Lord and an inheritance." Let us believe and pray. Father, we thank you that you have made us stewards of your people. And we thank you that these 2 days, Lord, you are coming to sharpen us. You're coming to help us put our heads together, that from different stakeholders, we can be able to see how better we can be able to serve your people. For Lord, we do not want to do it as unto people, but unto you, as the word is telling us. We thank you for every person who is represented here. Thank you for divine protection. Thank you for commitment. And thank you for the zeal they have in serving your people. It is our prayer as we begin today that you will be with us. We pray for guidance. We pray for wisdom. We pray for everything that we're going to do today in a discussion. The Lord, you shall lead. Not only that, we pray that this will be put in practice for the betterment of the communities. It is our prayer, the Lord, that the communities will change the tide, because Lord, you are entrusting this to faithful stewards. We continue to trust in you that all shall go well. Father, we pray for those who have not yet joined, that they're going to join us fast so that we can all begin together, because where there is unity, you command blessings. Lord, we also do pray that none will be wanting in the session and after. And we pray above everything, be exalted. We honor you and we bless your name. For this we do pray, believing and trusting in Jesus' name. Amen.
Amen, and thank you, Pastor, for that good word of prayer. I'll now go through the key highlights of yesterday. And before I start the program of the day, I'll request my co-moderator, CD, to also introduce herself for today's sessions and also give our remarks. CD, please.
Thank you very much, Francis. Hi, everyone. So I am very grateful that we have all joined. At least 85% have joined on time. So I'm grateful that we are here. We are ready to learn new things. We are ready to engage for today. And let's keep the session as interactive as yesterday. Yeah, thank you very much.
Thank you, CD and the team. So for now, we have today's sessions. I can go through the yesterday's program. And as a team, we were supposed to complete yesterday's program. And for today, what is very important is that we'll do the highlights in terms of the key remarks of what we did yesterday. But we'll also go ahead and give some opportunities for people to voice their perspectives in terms of what was discussed yesterday. And after that, we'll now go to the track 1 to track 3, group work and presentation. But what is very critical is that today we'll request the presenters and the people who will be giving their voices to adhere to the time allocated so that we can move together. So I'll now do the recap of yesterday. Key importance about the comment that came from the yesterday's discussion. It was a very important discussion in terms of how we are going to look at issues around the action plan that we are going to develop, and also look at how we can also be able to improve our program to focus on children. So let's go to the next slide, please. So what is very critical is that this program, looking at it, is that key highlight was that in highlight of time, we integrate comprehensive counseling in HIV and TB and generally all conditions require it. So in terms of service delivery, we need to really look at a comprehensive approach in terms of counseling and even in terms of implementation. The other thing is that what came out yesterday is that CCC must have time with clients at the individual level, listening to our brothers and daughters and sisters. They require a shoulder to lean on them. So there is that issue of how do we strengthen our relationship, looking at issues around the CCC issue, looking also at the issue of the service delivery, and even issues at how do we even beyond the service delivery be able to engage that issue of building the client in terms of the time that we offer and also listening to them very well. The other one is that there is need for adolescent-friendly CCC. We need to also have targeted programming that will be able to ensure that everybody is put on board and is well served based on the areas and also based on the age and also based on some services that are very special for specific group. The other issue on service delivery that came out was that we need commodity security. When it comes to access, when it comes to diagnosis and treatment, and for all of us, I think commodity is a very critical component of that define the service delivery model that we are doing. And it is very important for us to look at that component of commodity security in all program areas, including TB and HIV. And our partners are therefore need to take this as one of our key priorities that we really need to see how do we address. The other thing is that looking at issues around service delivery is the county laboratory coordinators. The laboratory leadership need to be part of our discussion and conversation, and even including the dialogue that we're having to take note of the delay in which might also affect the service delivery and especially the EID and infant diagnosis. So the discussion needs to be a bit more comprehensive, inclusive, and also participatory in a manner where everybody who provides services needs to be part of this game. Finally, is that we need to deal with issues around stockout. So we need issues around the drugs, the kits, and also looking at issues around the privacy of patients is very important in terms of information that is required. So we need to strengthen our advocacy, communication, and community engagement and information component to be able to ensure that everybody understands and everybody is aware of the information that is very critical, especially now that we are focusing on a very critical component of TB HIV. The next slide, please. The other one is that in terms of community response, as much as we are focusing on biomedical interventions on the first line, there is also need, especially in TB, HIV, and even care, we should not leave behind other component of behavioral and structural interventions that are also very critical in terms of comprehensive for programming. That means that we need to engage communities and continue to put communities at the center of both TB and HIV programming. The other one is that we need to ensure that community support and engagement is the way to go. So engagement of community will be able to give us a direction in terms of how do we optimize to scale the access and care for all, leaving no one behind. The other issue is that stigma and disclosure is a very major challenge. So we need to look at how do we ensure that especially the component of medication, the component of engagement, the component of putting everybody to be part of this and not discriminating anybody. We need to see how do we now address that. And it is very critical that the component of the facility, the component of the community needs to come up very well and really be able to support those two elements together. A lot has been done in both the adolescents and young mothers to addressing stigma, discrimination, using support groups, and also availability of medicine. So we need to see how do we now come up with platforms and space that will also be able now to enhance that very well. At the community level also, disclosure is very key, but there is a great challenge on issues to do with the disclosure and discrimination. So there is need now to see how do we assist in treatment and adherence as one of the components in terms of disclosure and understanding that that issue of giving out disclosure as a critical component can also be able to go beyond the levels that are there today. CHVs plays a very critical role in primary healthcare, especially component of primary healthcare concepts. So we need to see how do we now align or leverage on issues around these supported opportunities that are there, but more importantly, also look at the welfare of these CHVs beyond the service that they are offering as much as is a volunteer concept, and see how do we support them, especially in terms of ensuring that we have a better stipend for them. The other one is that at the community response, peer education and support and psychosocial support is very crucial in HIV care. So there is a need to see how do we strengthen that component of psychosocial peer education, and also looking at how do we incorporate the two in our implementation of the programs that we have. The next slide, please. So in terms of innovation, leadership and governance, child participation is very key in decision-making process that affect the children, especially for the adolescents in care. There is always a thrive well and cherish their safe spaces. So there is need to see how now that we need to incorporate the component of child participation in all this. There are different ways of approaching this, but we need to define as one of the innovative ways in terms of leadership and governance. How do we ensure that we are able to capture this? The other one is that we need to now strengthen our advocacy for better in terms of now the focus for children interventions, and also looking at issues around client-centered approach. So we need to see how do we advocate for us in different levels of our programming. The other one is that teenage pregnancy is a big issue. So how do we ensure that we are able to come up with programs based on the reports that we have to be able to ensure that issues around different levels, different platforms that are there are aware of interest, especially issues of capturing what is very critical in terms of the growth and process of nurturing our adolescents, especially now that is a big challenge within the HIV component. Finally, the last slide, please, is that we need to look at issues. If a mother has tested positive, they should encourage to come with their support, with their own support to share and also give professional counseling. So there is need to ensure that as we move up with this program, there is a way that we need to empower to disclose to their significant others, and we also need to also be able to give the guidance in terms of who are these people that are very important to be able to be given this information. Finally, as we move with this program, Negligence by mothers is being assessed, and there is need to see how do we ensure that clinical assessment, comprehensive clinical assessment, and mental health support is also incorporated in our programming. So there is need to see how do many mothers that are struggling to ensure that other components that also affect them, like partner violence, anxiety, and depression, are also taken care of. So with that, that's the recap of yesterday. That's some of the key highlights, but we'll also move to giving you opportunities to be able to voice your perspective so that we can also be able to move together. I'll now hand over to my co-moderator, CD, to move the program from there. Thank you, and over to CD. Thank you.
Thank you very much, Mr. Francis. So the next part, I will just want to ask participants if any of you has anything to say onto what already has been mentioned, something you feel was very important in the key highlights that has not been mentioned by my colleague, and maybe I can give three or five people, if any is available, and then we will move on to the group work. Do I see anyone's hands? If anyone, I don't think anyone's hand is up yet. So I hope that means that we covered everything very well, and we were very conversant with what came in yesterday. If you raise your hand, you will be unmuted so as to speak. So I'll just give this one more minute, and then we can move on. If there's none, we can move on to the next session. Okay, I think Jen Wanjiru can start. And this is just also an opportunity for anyone who is in the call to speak their mind, maybe what they were not able to say yesterday. We're just giving you an opportunity because it is very important that we actually hear the voice of the people that we are reaching with this information and just the session in general. So if you feel like there is any part that anything you had wanted to say during yesterday's session, you're also free. But in the meantime, I think we can have Jen Wanjiru. So Jen, you have been made a co-host, and you can be able to unmute yourself and go ahead and speak.
Thank you. Good morning, everyone. I'm happy and glad to be here this morning. The part that we also shared yesterday, and I didn't feel like it was highlighted in the recap, is about the TB diagnosis in children. And I think we also talked about having a champion for children, mostly in the facility setups, someone who will always champion the issues of a child. And this one also goes to the concern, not only in the CCC clinics, but also in the MNCH, in the child triad centers. Any child who seems symptomatic, any child who presents with a symptom, I think it's important we also reinforce on the championing of this child getting access to care and also to diagnosis. Thank you.
Thank you very much. Yeah, I totally agree that we need to have champions for children. They might not be the children themselves because children cannot sit at the facility, but we need to have people at the facility who will always follow up on issues to do with children. So thank you very much for reminding us that. Stephen Chikoli.
Yeah, thank you very much. Good morning, everyone, and thank you, Cindy. I think I've followed up in the conversation, and it was wonderful. And just to echo what the previous speaker, Jane Wanjiru, has talked about, the importance of having TB champions, especially those who are focusing on children, and they don't not only discussing or focusing on diagnostic, but also focusing on prevention. I think prevention is very key. And once we focus and we embrace the issue of prevention, especially TPT, there is the TB prevention therapy that is very key. And we are missing a lot of people because we don't know how TPT works. I think it's all about now delivering the information rightly to the community and having key people like champions, especially those that will be championing the TB prevention therapy, especially to our young children. It will be very key, and we will go hand in hand in reducing the TB infection or the rates of TB in our children. I think that is very key. And I think a team from TB program and Akina Evelyn Kibuchi, we can think about that and also see if we can at least develop some few champions in all counties to ensure that at least each county has a champion for pediatric TB. Thank you.
Thank you very much, Stephen. I think the sentiments have been well taken in regards to TPT and having a pediatric champion. Any other person who hasn't had time to speak? Okay. So in the chat, I saw Zilpha. Zilpha had put down something on male engagement, especially mental fathers, was also mentioned in the community subcommittee, which is very important. Definitely, we all agree that male engagement in terms of supporting our children and our pediatrics is very important at all times. However, we have left men behind in most of these processes regarding pediatric HIV and TB. So that will also be a very good consideration to put forward. Okay, in the assumption that now everyone has spoken what they had to say, I hope everyone is able to hear me.
I can hear you, Cindy.
Okay.
Good and clear, Cindy.
Okay. So if everyone can hear me, then I think we can go to the group work that you were supposed to do. I hope you guys yesterday when you were registering for yesterday's on yesterday's link, you guys pre-selected the tracks that you guys will be going into. So there is service delivery, there is community response, and innovations in terms of leadership and governance. So there are going to be three groups. One, the first group being led by Dr. J. Onentia and Marianne Mwangi.
I can see Ludfin's hand is up. Cindy,
Okay.
Ludfin's hand is up.
Ludfin, you can go ahead, and then I can continue just for a minute.
Good morning, everyone. Cindy, am I audible?
Yes, I can hear you very well.
Thank you so much for great moderation this morning and for giving participants time.
Hey, how are you?
Time
You
to be
okay?
able to interact. We encourage more interactions, and I think we have the national with HIV in the meeting. Perhaps Nelson would want to make some contributions, if we could allow him. Thank you.
Okay, so Nelson Otoma, you can unmute yourself and speak after you have been made co-host.
I think we are doing fine. I think I think just to echo the commitment that we were making yesterday from all partners in need to end HIV and TB among children, and the agreement that this needs highest level political leadership, because we have been trying. And yesterday, you remember, I was putting in the chat, everybody's committed, every institution, every agency, yet children continue to be left behind. So I think the point I wanted to emphasize is how we leverage on the political leadership, so that when we talk about stockouts, we talk about reagents. Stephen Gua was talking about TPT, and these prophylaxis and these treatments are missing. And I think whether you talk about communities, parents, community health workers, or program managers, or those who deliver services, they are helpless at that end. They may not do much. I think the much can only be done by the highest political leaders and the funders. And I'm happy to continue having that discussion as we go for group work. Thank you.
Okay, Nelson has already started on community responses and leadership and governance parts. So as we go into group work, maybe what Nelson has said will be very important to consider in our group works. And just to echo that everyone should, as everyone joins the group, especially the leadership and governance, and people are discussing commodity stockouts, that they can actually come up with solutions that are very key in elevating the cry of the pediatrics in terms of the stockouts in the commodities. I see Maxwell's hand is up, and this is the last person I'm letting speak before we go into group work. So Maxwell, you can go ahead.
Thank you very much, Cindy. Good morning, everyone. Sorry for the late introduction, but I think there's something that was mentioned by from the group work we had yesterday for the governance piece. But also, I think what Nelson has just brought up is very important, I think, across all the three groups, that I just want to mention that and recognize that the faith leadership already has MOUs signed between the faith sector and the county governments. And then also they have another MOU signed with national government, specifically with Ministry of Health. So I think there's already a framework that is already been set within the faith sector action plan. I believe through NAC, we've been able to really start working within existing structures. So my plea is perhaps to challenge also the folks in all the groups for those representing the faith sector, but then really honing in on the issue around pediatrics, HIV and TB. And not only that, I think malaria is also a big issue for those who are under 5, and immunization as well, just to really start honing in on existing frameworks and how we can expand and use the latitude we have based on those MOUs. So I'm actually asking the faith leaders in this meeting, in those groups, to give us some updates of where those two particular MOUs are, how impactful they have been. I know for COVID, they really were very helpful in terms of structures to help in mitigating COVID and engaging the faith sector in a structured way. But for us here, to help us really not reinvent structures, to see where we can build off of those two opportunities. That is just my plea, but I also just wanted to see if they could speak to it at some point to give us an update of where they are with that particular setup. Thank you.
Thank you. Thank you, Max, for those comments and giving us insights even as we go into the group in regards to the faith sector and how they can show us the effectiveness of already what has been happening, and then how we as the community maybe can use the same approach so that we do not have to invent the wheel over and over again. So thank you very much. So we'll be moving on to the group work. So as you all know, there were we had 3 different groups, and the first one was on service delivery, the second one was on community response, and the third one was on innovations, leadership, and governance. And the first group shall be led by Dr. J. Onentia and Marianne Mwangi. The second group shall be headed by Zilfa Samoei and Jackie Wamboi. And the last group shall be headed by Dr. Violet Oramisi and Grace Kariuki. In this group, we shall be addressing urgent issues and concerns in this area. So let me just take you a little bit back to the presentations that we had yesterday. So we did have presentations by 3 key speakers, and we did service delivery solutions and actions related to support systems to retain mother and child to care, community response on solutions and actions related to support systems. And here Maureen Murenga really gave an insight of already what is going to feed into the groups, the solutions and the challenges already that are being faced. And then we went to leadership and governance on solutions and actions related to support systems. So here basically we were having a lot of information, we were being given a lot of information on the exact solutions and the challenges that different mothers are having in the community, but also in terms of the systems that are available to support the mother to attend to her child, and especially when they're young. So in regards to that, we can all break into our groups. I will be sharing my screen on the urgent issues, on the things that we are going to address. So IT, just give me a minute and I will be putting it up so that we are able to see what you're going to do in the groups instead of me reading them, because you might forget.
Go ahead, Cindy.
Alternatively, Edwin, do you have the program on hand? Because I can't seem
Should
to
I
find
project?
mine. Yeah, I just want you to project the parts where the group is supposed to go and do the specific questions they're supposed to think about as they go into their groups.
Sure, shortly.
Okay. I think that's it. You just need to enlarge the screen right where you were before. Yeah. So if you guys are able to see the screen, these are the main things that we will be going to address. So the urgent issues and concerns, the actions and solutions your organization could offer. And here we will really be looking into all the different groups. What exactly are their organizations willing to offer in terms of these challenges that we will have already mentioned in the first question. And then what would you need from other stakeholders? So what are those resources that you will need to so as to respond to them? Things that are the solutions you want to give and such kind of things. So IT can take us to the different groups, and the group leaders can then screenshot the parts that have been put forward on the tracks, and then they can lead their groups very well. Thank you.
Okay, so Cindy, we have done service delivery so far. So, but there's no problem. All team members will see there will be a pop-up on their screens. So they'll just be able to choose which discussion group they will be interested to join. And it will go that way. So once you see a pop-up on your screen, then you'll just choose which breakout room you would wish to join. But for those ones whom we've already selected, they'll be able to join their groups immediately.
Okay. Okay, so I think you wait for the pop-up. However, for the rest of the people who will be on the call, you will be directed into your own group. So if you are using the if you're on this chat and if you're using your laptop, there is somewhere that is written breakout rooms, and you can be able to click on it and join as per what you feel is comfortable with you. Okay. I hope everyone is back from their breakout session, and I will just be giving each group a total of 10 minutes to present for each group. So I will be starting with the group number 3, which is the innovations in leadership and governance. So group 3 can go ahead and present. So IT, if you could please unmute Grace Kariuki. Or Maureen Inima.
Hello, everyone.
Hello.
This is great. I hope you can hear me. Cindy, you can confirm?
I think we can hear you, but it's a bit low.
Okay, I'll try speak to the mic quite closely.
That's better.
Okay, thank you so much. So we were tackling the issue that was raised yesterday on how to support the systems to retain mother and child to remain on HIV care and routinely investigate the TB and HIV / COVID, obviously. So there were a few main issues that were raised. The first one was that there is a proposed bill to impose tax on milk formula that is currently in Parliament. And we saw this is going to be a challenge, especially for mothers who are already struggling to actually just buy it at the normal price. And so the issue is how can the different stakeholders play part in this? The second one is to create a national environment that foster innovations on programming. There was someone mentioned that internationally donors frame problems and then throw them to the researchers and scientists to provide a solution. Can we do the same here, or has the same been done over, and can we ride on what is already happening? And then the other issue was on lack of data and how can the stakeholders capture and record correct data that can inform policy funding on issues to do with pediatrics, which is both numeric and qualitative. So on each of the issues, we started with the lack of data, and we said that it is important for stakeholders to develop user-friendly data collection tools, because this data is actually collected in the community, and if the community health worker does not understand it themselves, it would be very hard for them to collect the right data. So they need to be able to have one that is usable, that they can write reports from, and can be given that the information will be useful for the people who will eventually gather it, whether it's the researchers or policymakers, to make informative decisions. And then organizations also need to motivate the community health workers. I think this is an issue that has been there for many years. How do they motivate them adequately to be able to go deeper into the work that they are doing with a lot of motivation? And then we also said that there need to be innovative ways to collect data, especially in rural areas. The tools need to be more specific to the mother-child information that we want to collect, and not, they need to be disaggregated so that when they're collecting from other populations, they also capture the information that we require from mothers and the children. And then we need to create linkages with groups that work with mothers to assist to collect proper data so that we are actually working together. And that's also what comes to the work that we are saying, the last question where we are talking about resources. What kind of resources do we require from other groups? And this is it. How can we leverage on other groups that have got support groups or mother-to-mother initiatives that we can actually work with? On the issue to do with tax on the milk formula, we say that it would be important maybe for the stakeholders in this forum to come up with a statement that is clear and concise, that can be shared with the Parliament as they start the discussion, so that we can see whether this bill can actually be suppressed or be done away with. And then we could talk to and lobby with children champions in the Parliament or Friends of the Children on these issues, and possibly start with MCAs in our different counties and see whether we can start talking to them now, so that as they go to the Parliament to talk, then they have this already in mind. And then also the issue of formula versus breastfeeding, because that's something you'll be challenged on. We are talking about this being, I think someone said, a breastfeeding nation, but then you are also trying to talk about a reduction on formula or doing away with the tax. So how do we lobby with this in mind? On the innovation fund, we talked about how can the stakeholders here and others that we work with could provide support letters in agreement to the proposals that are being sent out. And that means all our data that we are sharing should be shared with the people that we are generating, should be shared with the people who are actually writing these proposals. And then we support them as with letters from our different sectors. And then how do we ensure the interest of children remains firm and in the minds of our politicians and our policymakers, even as we look forward to the transition in the government? And someone said that we need to, there was a baby-friendly initiative. I don't know that it's international. I did not get that point very clearly, but that person can actually talk to it after this. And we can adopt it and push it forward so that we see whether that is something that can actually be included in all the discussions by our policymakers, our politicians, and wherever. And then we have to have constant advocacy and lobbying within our different sectors and our areas. So that is what we're able to do. If I missed out on anything else, please, my team, you can chime in. Thank you.
Thank you very much, Group 3. That was really comprehensive. Moving on to Group 2. Is it Brian or Zelfa? So in the meantime, Maureen is asking to be let to expound on the child-friendly initiatives. In the meantime, IT will find some. Can you please also give co-host to Brian Otieno? So Maureen, Unima, and then Brian. Maureen, you have 2 minutes. IT, okay.
Okay, sorry. So sorry about that. So yes, I was going to request that we allow for one of our members to just expound on that issue around baby-friendly initiative, just for a minute. If you can hear me, I think that was Rosemary, or was it Lucy? Kindly, please go ahead. Or you can as well just side chat and we can pick that point and add to Group 3 track rapporteur report back. Thank you. Over.
Okay. So in the interest of time, we can continue with the Group 2. And then if Maureen is side chatted, they can be able to give us more intel on that.
Okay. So thank you, Cindy. For group 2, I think much of this was already mentioned yesterday in Maureen Murenga's presentation. And what we were looking at was some of the gaps that were identified within the presentation and some of the things that the community felt lagging in terms of issues identified. So I'll just mention the issues and probably, as you mentioned, provide solutions as we proceed. So one of the issues was the long turnaround time for the diagnosis, like diagnosis feedback, which led to a lot of misdiagnosis among the children. The other thing was access to ID was quite a challenge. The EIDs, the early infant diagnosis, like this was an issue that was really identified in terms of this not being readily available and information being provided on where to access the services. Then linkage, mislink within community and facility. So there's note that there's a big gap within the community linkage and facility level in terms of knowing where to access service and who to reach out to in the community. And the case was provided on the same on issues where how community can be engaged in terms of just making sure that the children are accessing services and not feeling like they're poking their hands in their families with that need services. Then engaging young people was brought out by issues of CHVs, most of the CHVs being elderly, and having that we also need to reach out to young people. How could we engage and motivate young people to be part of the cohort that goes out to the CHVs in terms of service delivery and identification, especially for TB cases? Then stigma came out again, just as yesterday. There's still a lot of stigma in the community, both for TB and HIV, that needs to be addressed. Then children diagnosis procedures are not really clearly placed out there, and we really need to rework on that. Then there was lack of safe spaces in the community. This was in line with the psychosocial support, just providing safe spaces for communities to address some of the issues that they are facing. Then there was delay in results dissemination, which was mentioned in the long turnaround times that exist. So some of the solutions provided was providing psychosocial support groups at community level to help address issues of the ID, long turnaround times, a delay with the results of the diagnosis, and maybe just strengthening the turnaround time within facilities. How could you work around that? And this is more a system strengthening. Then having a seamless linkage within facilities, from facilities to community level. How do we strengthen that linkage system and the referral system? Then the other thing was engaging young people. So just make sure that we have trained young people among the CHVs and how they can also be mentored with the already existing CHVs to work together in providing services in the community. The other thing was establishing feedback mechanism for QA. So there's lack of feedback in terms of service provision, and we need quality assurance mechanism, which a feedback mechanism will also be very important from the community on how facilities are providing services to the community and how that can also be given back to the facility to improve their services. Then under stigma, we need to strengthen the community, the customer service delivery, and that is having a client-centered approach towards service delivery. So basically capacity building and doing frequent assessments, either through the QAs to the service providers on how best they can provide services to clients as they come to the facility, because there's a lot of stigma within the facilities that needs to be addressed. Then I need to strengthen systems in children diagnostic procedures. As mentioned, there's a long turnaround time. So how would we strengthen the children diagnosis procedures within facility levels that will ensure we cut down on the long turnaround times that are currently existing in the system. Then last but not least was having a multifaceted approach at all levels and all forms of engagement, either the community or facility level, in just making sure that we look at all issues from a religious point of view, societal, and also the biomedical, and not neglecting any aspect of it, because there's a lot of mislink in that. Then establishing safe spaces in the community, as I mentioned, there was that mislink within a community that there are no spaces for community to really address issues or provide their feedback on how services are being provided, also talk about the issues affecting them. Then teaching teachers on HIV and TB. So information, the current curriculum is really eloquent and providing a lot of information and less of stigma. The problem is the teachers. So I think there's still need to have a conversation, or rather a dialogue and a capacity to build the teachers on issues of HIV and TB. So who are some of the stakeholders we thought should be included? So on TB, we have the peer educators and TB champions, and also working with the children who play soccer, just to act as the champions or the voices or the community focal persons for TB advocacy. Then having working with the healthcare providers, as creating that dialogue, community dialogue between healthcare providers is very important. So there's need to engage healthcare providers seamlessly. Then the religious leaders also came in quite clearly that there's need to have the religious leaders on board. Then administration officers at the community level, these are the police, the APs, the wazee wa mtaa, the community gatekeepers are very keen engaging in terms of just addressing community issues. Then lastly, the education system, when it comes to training the teachers, these are one of the stakeholders that was identified in terms of addressing issues of stigma and providing more information on HIV and TB, especially for students back in school. I think that was it from the team. And lastly, there was the issue of engaging fathers as well. Yeah, that was a gap that was identified, and needs to also come out so clearly that fathers are not really being engaged as much as it's needed. Yeah. Back to you, City. In case there's anything else to be added from the team, kindly do so. And yeah, thank you.
Yeah, Zilpha, you had something else to add? Then we can go to group 1.
No,
you still have 2 minutes.
Not in brands group, not in the community group, but I'm reporting for the service delivery. So maybe once you exhaust, I can go ahead.
Okay. Anyone from the service delivery group who has anything else to say?
Cindy, may I add my voice briefly?
Yeah, Ludwin, go ahead.
Thank you, Cindy. I just wanted to put this challenge also to civil society, community networks that work on HIV and TB. The need for the networks and civil society to also really put the duty bearers on their toes on this particular issue. There is not many voices that speak pediatric HIV and TB. They are lacking. Perhaps the Murengas are very few. We need more of civil society to build their capacity on this particular issue, but also to champion coordinated advocacy around this issue, informed advocacy with research that can then continuously bring this issue to the core. I think the second issue I wanted to talk about is the linkage between the civil society coordination and the technical working group, especially at MOH, at the NASCOP. And Dr. Lazarus, this is a challenge we are putting onto your table to ensure that you are constantly bringing the voices of communities that are championing this particular subject matter to the table at the technical working group, so that they can be updated on the technical issues around this, but also that they can inform the decisions, the guidelines, and the policy direction that the country is taking forward. The third issue is the need to really put resources, put money, put technical support to technical capacity to community networks and their leaders, so that civil society and networks that are handling or championing issues of pediatric HIV and TB can have money for their own organizations, but also to advocate in a sustained and informed way. And my fourth contribution on this issue is that
from the civil society perspective, we will need to broaden our networks beyond the civil society, beyond the HIV and TB space, to include other networks and civil society that deal with children, whether they be on child rights or basically other organizations. So broadening our space so that we can then build a really strong movement that can help to really bring this issue to the core. That would be my submission for this particular segment of our work this morning. Thank you.
Thank you very much, Ludfil. You have really brought out also aspects that we had talked about but had left out. So thank you. And Zilfa, on to you to present for Group 1.
Oh, thank you so much, Cindy. So I will report on behalf of a service delivery group, which was looking at issues related to support system to retain the mother and the child to remain in HIV care and treatment. And some of the urgent issues or concerns which were raised are the number one, stigma and discrimination related to issues at school or at home for the children. Then the knowledge gap of healthcare providers. We had a disclosure of HIV status to children and inadequate resources that should be able to address issues of retention. So some of the suggested solutions and action points were as follows. For healthcare workers, there is need to do continuous capacity building and mentorship. And it was suggested that it is also good for facilities and counties to have innovative approaches, either at service delivery point or at a county level, which are specific to that particular region so that they can be able to address their issues adequately and bring on board issues of follow-up and for the children who are lost to follow up and link the facility and the community so that the children are brought back to treatment. Addressing issues of disclosure and follow-up at family level, the group suggested that there's a need for structured way of family engagement, either by having a treatment literacy guide for the mother and the family, probably developing one or using an existing one, and to support the mother and the baby and the family as a whole. And the issue of house helps also being caregivers and being nannies in most homes was also brought up, and that may need to be relooked into and see where their capacity building can be done either at family level or if a different treatment literacy can be developed for them. For commodities and supplies, there is need to address the issues of frequent stockouts, not only for drugs, but also for lab reagents so that we don't delay the viral load testing. And then to address the issues at school, I had the other presenters have also mentioned this, but there's need for multi-sectoral approach with the Ministry of Health specifically, Ministry of Education, just to ensure that there is that support at school for the children, maybe capacity build the teachers, even to be able to just do TB screening for those children and be able to support them to get, to make sure that they are here to treatment and to reduce stigma. It was also proposed that multi-drug dispensing, multi-month dispensing for 3 months so that when they are at home during holidays, they can come for viral load testing was also suggested. So that may need to be looked at. So capacity building for teachers is very key, and that linkage between the school and the health facility so that in case there is a child who has an issue, then it can be reported to the health facility and that can be addressed. Also engagement of religious leaders and CHVs to handle children and adolescents, to trace them at the community level, and also to be able to do TB screening at community level for those who are not in school, and then advocate for stigma reduction intervention. Resources that may be needed in some of those activities included engagement of children's department, especially where children are living in foster homes and they're having challenges. So the children's department can be engaged to support. there is need for advocacy at county levels to allocate resources and money for TB and HIV for children so that we are able to address some of those gaps, and also encourage public private partnership participation for resource mobilization and resource sharing also at different levels. And some of the other issues that were raised in that group were that there is also need to ask stakeholders to come up with an inventory of OVCs from the Children's and Social Services Department, so that at any given time we know where the OVCs are and how they can be supported, and for also easier follow-up. Also, the issue of child protection and their rights also came up, so that there's need for that link so that children can be protected to realize their dreams, and also so that in case there are any legal issues, it can also be addressed. I think that is a snapshot of what was discussed. Maybe if the group members feel that there's something I could have left out, they can raise their hands or address in the chat box. Thank you, and back to you, Cindy.
Thank you very much, Zilpha. And I'm just going to read, I think, one chat by Simon Rono, who says, default tracing exercise can be done nicely by top people. That is the CHV and the community health. I don't know the last part, so but I think it's a community health worker. The CHV man a number of households and can easily trace their contacts by joining hands with the community health workers, and this can be done successfully and supported, and they can be supported to do the same. So it is community health worker, it is community health volunteers and community health extension workers. So I think the idea is that default tracing, which is, I think, the wrong term. I think we are looking at people who have been lost to follow up. And so while we are doing tracing of these people who are lost to follow up on these children, that we can use community health volunteers and extension workers to reach out, because they do man a specific number of households who and they directly know exactly where they should be. And so they can be able to reach out to the specific people that they want to reach to. So thank you very much, Group 1. I think for me, what was very interesting is that in all these groups, it was clear that everyone wants to ensure that children are well taken care of, children are safe, children are able to access their services, children are able to access their commodities when needed, and that we can collaboratively, whether be it communities, community health workers, stakeholders in different departments, can all jointly come together and promote the needs of the children. So thank you very much to all the groups. And so we shall be moving on to the next session, which will be moderated by Evelyn Kibuchi and Dr. Philip Owiti. But before that, we will play a very short video of an AYP perspective for the group that was for the gentleman who was unable to give the perspective because of microphone issues. So in the meantime, Wilson Lore's video will be playing up next while the next presenters take over. Thank you very much.
Hey, hello, I'm Lore Wilson. I'm age 25. I was born the late 90s, and I started my antiretroviral drugs at the year of 2003. The year 2003, I was still young. I wasn't able to understand what was going on to me. So slowly by slowly, years to go, years to come. In the year 2003, I was still able to continue taking the drugs because I didn't understand what was going through me. At the year 2008, adolescence age, due to peer pressure and issues relating to the adolescence age, I was having some a lot of challenges, mostly because I've been taking this drug since childhood till the teenage age. And I think for me, to the family, it wasn't right time because they were not able to know how they would start this issue. Why do I take those drugs? So for me, I pressured them and I was able to be taken to a facility where I was being able to be told everything about me, my personal life, whereby I wasn't ready personally, but the sisters from the facility, they were ready due to the age bracket which I was, and they were for their decision to provide for me to know my status. So they gave me a booklet whereby it was written the whole issues relating to me, and I took the paper, I read it. I read the paper for more than like 5 to 6 minutes. So I started to understand what was going on to me. So it wasn't easy for me to accept because a family of 7 children, it's only me, the last born daughter, whom I turned it positive when the mom and the dad wasn't in a good condition. There was no one who was positive beside me from our family. So it wasn't easy for me to accept what was going on to me. So slowly by slowly, I was welcomed to different kind of youth groups, which I was empowered, well empowered, giving information, being told that taking the airways in the last of my life. So life must go on, must think about the future, the family, and the children. So still after being disclosed, there was no any other decision for me to make because I was told I will be taking the antiretroviral drugs till the end of my life. So because I decided myself, because I know that I still need life, I must decide that things must continue to go on. Because it's only God who knows what will happen else in my future. The mostly challenges which I faced was mostly issues related to the nutrition. As we know, the drugs are very strong for us. We are able or we are supposed to do the precautionary. Challenge was still more because, as we know, sometimes there was no food at home, and I was supposed to take these drugs. So I wasn't able to sustain myself, but I thank God for this far I've been going through. So it reaches a time whereby I decided on my own that it's only me to decide what to do. So I followed the sister who discloses to me, and she told me everything, and she told me that I'm not alone. There's a big family whereby we can come together, assisting each other, share the challenges we face. And that day, which I was welcome to that group, I saw a very big family of youths whom they came together, settled, and talk about what they are facing, the challenges, both challenges and challenges. And there was no any other issue for me to do, so it was only good for me to accept what was going on. I have the virus, and there's no way which I can take it out from me. So the only thing I decided to do is to join the support groups from different youth groups from different sub-counties in Changamwe, and I was able to be announced as one of the champions within Changamwe under the group known as Southeast Kika. And for the place where am I now, I really appreciate because I've been given a lot of opportunities from different youths to represent the LLHIVs and give them support, show them what's good for them, and telling them that there is at the end of the life. So we must go on, we must fight stigma, discrimination, and it will be one of our achievements under the 95 strategy. Thank you.
Thank you very much for highlighting key things that helps young people to overcome challenges in when they have been disclosed to things such as treatment literacy and having a support system so that you can be you can be very open about your status. You can be able to come out strongly and accept your status, as well as be very adherent to your medication. So thank you very much. And I will hand it over to Dr. Owiti and Evelyn Kibuchi.
Thank you so much, CD, and thank you, everybody. Thank you, all the moderators of yesterday's sessions and even the summaries of today. These have been very, very productive and informative sessions. Let's see what the day holds for us today. Today, we turn the pages and we are going to jump straight away to the sessions for today. And the key priority areas for today are: one, to come up with solutions and actions related to equitable access to technology for diagnosis of TB and TB-HIV co-infections in children; to come up with solutions and actions related to gaps in data management system limiting, permitting progress, tracking data disgression. And able presenters, the topics that they are going to discuss. The first presentation will be technology for diagnosis for and TB infection in children and effective data management, to be delivered by Dr. Kisia. Second, we're going to be taken through community response to equitable access to technology for diagnosis of TB and TB-HIV co-infection in children and effective data management. Finally, we are going to look at innovations, leadership, and to promote for TB-HIV co-infections in children and effective management. Thematic areas. After that, we shall come back to present the findings from the group. Without much ado, I want to invite Dr. Jackie Kisia. Dr. Jackie Kisia is a medical doctor with more than 20 years experience. She's program as mobilization. She was editor of Bulletin, member of the Respiratory Society of Kenya, RISOC, member of the Pan-African disaster response. Dr. Kim, you're welcome. Hello. Dr. Kisia.
Dr. Jackie, you've been unmuted. You can go ahead and speak.
Dr. Akisia? Give us a few seconds as we try to sort out her mic. We should be back in a few seconds.
She's trying to speak, but somehow we are not able to hear her. Give us a moment to sort that out.
Logging out and then we can mic issue sorted out. So give us just to be sorted out shortly.
Tunashukuru twasema asante.
Yeah, we are still trying to sort out the technical issue. We are requesting the person on the technical side, if she can reach out to Dr. Kisi on her phone and see if they can assist her. Because she was in another group and she was talking and we could hear. I think it's just a small problem that has occurred. So the technical person can just call her and try to fix her. Thank you.
Can you try talking, Dr. Kisia?
Hello? Yes, it's written here, the host is not allowing participant to unmute themselves. So,
Dr. Jackie, we can hear you.
you can hear me now?
Yes.
Okay. Okay, thank you. Can everyone hear me now?
Loud and clear, Dr. Jackie.
Thank you. Okay. HIV co-infection in children and effective data management. Next slide, please. The burden of tuberculosis in Kenya. Kenya is listed as the 30 high burden country in TB, HIV, and drug-resistant TB, according to the World WHO 2017 report. It's also a major public health problem and the fourth cause of death among infectious disease. It has a triple burden, that is TB, multi-drug resistant TB, and TB HIV. Next slide, please. The snapshot on Kenya's performance. Our target annually is supposed to be 140,000 case notification of TB. And overall, that is adult and children. We're looking at the first case finding in 2020. The first slide, we have 72,943. We are actually missing more than 50% of cases. And looking at the case finding over the years, compared to 2019, we have dropped 16%. And also looking at over the years, in 2009, we had notified 106,000 cases. And in 2020, we are at 72,000. We are actually missing more than 50% of the cases. Finding pattern from 2016, we were at -7%. Compared to 2020, we have really dropped to -16. In pediatric contribution, over the years, we've not been doing well, but we range between 9%, 10%, but could be because of COVID. 2020, we dropped to 8%. These are the counties which are being affected in terms of the highest drop. We have Nairobi, Kilifi, Trans Nzoia, Busia in pediatrics, and also overall, they are the same counties which had the highest drops. Next slide, please. We have to appreciate this map by looking at the way TB is distributed. TB is all over Kenya, and appreciating the middle belt from Turkana to Kitui, where we have the highest burden. We are looking at these regions. They are not so high in terms of prevalence in HIV. So it's not like TB affects more in HIV co-infected patients. We can see like Kisumu, Siaya has the same burden as Turkana, Samburu, Isiolo, Meru, and Kitui. We are also seeing a rise also in Mombasa, where it has, it's one of the counties which has the highest burden. Next slide, please. The TB diagnosis and care cascade. As I have said earlier, that we are missing more than 50% of patients not being diagnosed with TB. So definitely the TB is in the community. And once a person is exposed to a person who has, a patient who has open TB or active TB, they develop symptoms. And once they develop symptoms, they either seek treatment or decide just not to seek treatment. So it depends on the care seeking behavior. So we also have a strategy for case finding where we screen TB in all the integrated service delivery points, and also in school health. We also sensitize the teachers to be able to screen children and refer them to facilities. So after screening, they will be subjected to evaluating whether they are presumptive patients, and then referred to the lab. At that point, some of them, when they are referred to the lab, they might not go to the lab, so we miss that opportunity, and others are also go to the lab, where the diagnoses are done either by gene expert, microscopy, or chest X-ray. During that time, we also can miss the opportunity of starting a patient who has been diagnosed with TB by either the patient not coming back to the facility. So we lose that opportunity of starting that patient on TB. And if they come back to the facility and get their results, they are initiated on anti-TB. They are put on anti-TB, and some also follow up with treatment and complete their treatment, and they're cured, while others have issues with adherence, or also they're classified as lost to follow up. So this patient, we also have a strategy where we follow up and do contact management, where we screen them, and if they have active TB, they're put on treatment. Next slide, please. In the SEF care cascade, the opportunities which we have is build capacity among healthcare workers in screening TB, and also diagnosis, on-job training, and mentorship. We also have innovation around linkages with existing community strategies to screen children, optimize collaboration for TB with other program areas, and identify and scale up highly impactful innovation and initiatives. The challenges which we'll face is limited capacity. We get to train the healthcare workers, and maybe they are transferred or they're moved to a different department. So it becomes a bit difficult. Also, suboptimum linkage of presumptive TB patients, limited innovation and initiatives to find missing children with TB, suboptimal capacity for nutritional assessment in most lower facilities, because we know that if the nutritionist and the clinician work as a team, we'll be able to actually get a lot of children who have TB. Also, gaps in reporting and recording. Next slide, please. In diagnosis capacity of gene expert and X-rays, we can appreciate the fact that out of the 5,633 pediatric cases notified in 2020, 39% received a gene expert test. This will help in terms of treating the right TB. Is it the right type of TB? Is it drug-resistant TB or is it drug-sensitive TB? Which we should appreciate the fact that bacteriological confirmed and clinical diagnosis over the years. Initially, we were doing 97% clinically diagnosed. With training, and we have concentrated more on lab tests, that is the gene expert or microscopy, and we have improved over the years from 2015, where we were at 3%, and now in 2020, we are at 17%. The opportunities we have, the WHO recommended diagnostic of molecular tool, the introduction of stool as one of the specimens to diagnose PTB, and use of artificial intelligence through the card, which usually evaluates and interprets chest X-ray, and it's used in the digital X-ray, and eventually helps a clinician to make a diagnosis of TB, pulmonary TB. When we look at the chest X-ray, it's still a tool, a very important tool of diagnosis, especially in the young age, where between 0 to 4 years, these are children who can't follow instruction in terms of telling them to cough, to produce sputum, and looking at the abnormal suggestive TB X-rays in children who are between 4 and 6, 62% of these children had abnormal X-rays, and at the ages of 5 to 9, 48.6 had abnormal chest X-ray, which are suggestive of TB. Challenges which we are facing is limited capacity among healthcare workers in terms of doing nasopharyngeal aspirate and gastric lavage, with also the pandemic of COVID-19. Healthcare workers are not so comfortable doing nasopharyngeal aspiration and gastric lavage without PPEs. And also sometimes you get just healthcare workers not wanting to do the procedure because it's a bit difficult for them to do it at the outpatient, or either their attitude, they're just not, they don't want to do the procedure. So they will go for easier procedures or tests like chest X-ray. Also limited engagement of lower level facility in diagnosis of TB in children. We also have gaps in translation of policy to practice in pediatric TB cases and management. Next slide, please. Pediatric contribution from 2014 to 2020, as I alluded earlier, it ranges between 9% to 10%. But in 2020, we had a drop, maybe because of COVID pandemic. Private sector contribution it's 13%. The co-infection, we are seeing HIV testing is at 96%, and appreciating the fact like a co-infection is at 14%, maybe because the pandemic has moved, has dropped. And the ART uptake is at 100%. The distribution of notification of pediatric cases by age. As I mentioned earlier, that the burden is in the ages less than 2 years, 2 years and below, and rises pre-adolescence towards adolescence. So we can see the 2019, the cases were higher compared to 2020. But what we should appreciate is the fact like the TB burden is higher in the children who are less than 2 years, of 5 years and below. Proportion of BMI category for food support. The severe malnutrition, we had around 24%, and we put 37% of those children on a food supplement. And also looking at mild malnutrition, we had, we had 8%, and 8 of them were put on food supplement. The successes is adaptation and nationwide use of new pediatric formula, which are child-friendly, stable supply chain pipe, pipeline for pediatric medicine, engagement of private sector in TB control, pediatrician and associations engagement, and also opportunities, community engagement and private sector engagement. Next slide, please. Treatment outcome among pediatric cases in 2019. We have patients who were put on treatment. The treatment success rate was at 80.1%, but the cure rate is a bit low at 60%. This is the reason for this is for children, you need for evaluating patients on treatment, you have to do sputum tests in month 2, month 5, and month 6. Dealing with the children, it's hard for you to get a sample and continuously repeat either a gastric lavage in month 2 and in month 5 and in month 6. So you get the cure rate is a bit low compared to the treatment success rate. When we look at the core infection of children who have died, we have mostly the core infected children are the ones who are affected most. Like in 2019, there is the overall patient who or children who died were at 4.7%, but 12.1 were co-infected. Loss to follow-up is at 3.9 and failure rate is at 0.7. Next slide, please. The co-infection rate in pediatric in Kenya is at 14%. We want to appreciate the fact that Vihiga, which is not one of our usual high burden in terms of co-infection, is the new kid in the block. There's 40% and it's the highest in co-infection. Usually we have the Siaya, the Kisumu, and Homa Bay, but I don't know what's happening with Vihiga. Now it's at it's coming up very fast, and it's at 40%. We also want to appreciate the fact that in Northeastern, it has the lowest rate. At Wajir counties, Tana River, and Mandera could be because of the cultural way of living. Next slide, please. HIV among children initiated on TPT, 0.5% of children have been initiated on TPT. We have a lot of work to do here. Comparing in 2017, where we had 4.7 initiated on TPT, there is a big drop in 2019, where we have 1.5%. Next slide, please. Comparing option for LTBI, Next, please. We have the 3 options where we have rifampicin and isoniazid for not given for to patients who are on PI and nevirapine. And the other option is rifampicin and isoniazid, and it's not also given to patient on PI or nevirapine based ART. The best option still stands at isoniazid for 6 months. The other 2 regimens are taken for a shorter time, which is 3 months. And for isoniazid is taken for 6 months. And it's still the best regimen for people living with HIV on heart, but there is poor adherence and low completion because of the duration of time, that is 6 months, and high rate of hepatotoxicity compared to other regimens. Next slide, please. The challenges faced, we have inadequate training for frontline healthcare workers on the new TPT recommendation. We have just revised our TPT treatment, and also inadequate advocacy, communication, and social mobilization activity to create demand for TPT in the community, and also impact of COVID-19 pandemic has been felt on TB services, resulting to a drop of TB cases being notified. This is reduction also affecting the provision of TPT in the household. Next slide, please. Challenges, we also have decline of case finding, as alluded earlier, in children. Also in access to nutritional assessment and therapeutical intervention for severe malnutrition and mild malnutrition patient, and contact management missed opportunities. That was my presentation. Thank you. Back to you, Chair.
Thank you very much, Dr. Jackie Kisian, for that enlightening presentation. You've set the stage for us to continue with all these discussions. So just to try and summarize in a minute what you've been able to cover, you've taken us through the burden of TB in Kenya, the cases which were notified last year, a snapshot of what was missed, and also what proportions were pediatric, and you mentioned that it's at 8%, which is still quite low against a target of at least 12%. You've taken us through the patient pathway and the health-seeking behavior, which helps inform how to essentially get patients into care. You've taken us through the ACF strategies with the focus on finding children, the opportunities and the challenges. In terms of diagnosis, you walked us through the expert and the expert diagnosis, the X-ray and the use of artificial intelligence. Then towards the end, you took us through the pediatric indicators, stressing on the co-infection rates and also the treatment outcomes, amongst others. Then finally, you've taken us through the TPT, focusing also on the regimens available, the challenges and the opportunities which are also available for us as a country. So thanks a lot. And the members may continue asking questions even during and participating even during our groups. I now take you to the next presenter, who's also my co-moderator. She's Evelyn Kibuchi. Evelyn Kibuchi is a global health advocate, strong focus on tuberculosis. She has over 10 years experience in TB response. She currently serves as the Chief National Coordinator with the Stop TB Partnership in Kenya, and also the African Director of African Parliamentary TB Caucus. She is also a member of the Civil Society Task Force in the WHO TB team, and a member of the ACT-A, which is a COVID Commodities Advocacy Coalition. She's experienced in global health advocacy, engaging the political leadership for advocacy, media, and civil society, and community engagement. Before she joined and decided to spearhead the world of TB advocacy in Kenya and Africa and even beyond, she worked in different aspects of health research, including sexual reproductive health and vaccine development. So she will be the next presenter, taking us through the community response with regards to access to technology and services for diagnosing and treating of TB. So, Evelyn, the floor is yours.
Thank you so much, Dr. Witty, for the introduction. I first want to make sure that I can be heard well.
Yes, at least I can hear you.
Okay, without breaking, right?
Yeah, although there's a bit of echo on your side, we have logged in into two devices, and so you might need to unmute, to mute the other.
Okay, that's okay now?
Yeah, this is better.
Okay, thank you so much. Dr. Kisi has set the ground on pediatric TB issues, and mine is to bring the community, the aspect of the community response to equitable access to technology for TB clinical diagnosis and TB HIV co-infection in children, and effective data management. So my presentation was to touch on the burden of TB, pediatric TB in this country, but Dr. Kisi has done that, so I will beg to skip that, and I will straight go to what are the gaps in access to technology, and what have the communities so far done, what are the opportunities, and what are the challenges that we need to address maybe in the discussion that we are going, group discussions that we are going to have today. So that's a summary of the burden of childhood TB, which again, Dr. Kisia has alluded to. I wish to skip that. Let's go next. This is a list of the technologies that we have. Again, they were in Dr. Kisia's presentation, but just for a reminder, we have the Gene Expert, we have the X-ray, we have microscopy, stool test, TrueNat, the TB LAM, TB prevention therapy, and we also have the children-friendly formulation for TB treatment, which is a new technology and the reason we put it here. Next. So where are the gaps in access to technology? One, there's limited access to recommended diagnostic equipment. And in the previous presentation, Dr. Kisi has mentioned about the number of children that have been able to access the Gene Expert. Only 39%, which is that it's quite low. And that takes me to the next point, limited access to Gene Expert for children. Gene Expert is the first diagnosis of choice as recommended by the national guidelines. But still, we can see children have not yet been able to access it. Limited access due to cost. X-ray is one of the diagnoses that is used to diagnose TB in children. However, in Kenya, it's only free to children below 5. Children below 15 years are still charged for this X-ray. So that limits access to this crucial diagnosis for children who need it. Nutritional support, Dr. Kisi has mentioned about it. Low uptake of TPT. Again, TB prevention therapy is one of the recommended prevention that would bring down new infections among children. But we still haven't been able to put 100% of all the children who qualify on it. We are still using outdated technology for testing children. Data from 2019 indicated that 18% of the TB children were diagnosed using the smear microscopy, which is pretty outdated. That means there is a gap. Again, according to the TB prevention guidelines, we are supposed to initiate TPT for children below 15 years. But as it is now, we are still working with the limit of 5 years and below. Again, there are challenges that are still holding us back from going to the recommended age limit of 15 years. The other problem or the other challenge is the post-TB care for children. Though there may not be maybe data, but we have come across children who have had complications after they have had TB treatment, but we don't have proper care to take care of those post-TB complications among children. Next. Next. Okay, so what are the commitments that bind us, or what commitments are we working towards? In 2018, there was the meeting of the high-level meeting of heads of states where they met to discuss the agenda of TB. And in that meeting, they made a list of commitments that they were going to work towards. And a number of those commitments were focusing on children. And I'll just touch on three that touched on children. One, it was diagnosis. The second one was prevention. And the third one was on drug-resistant TB. So what did the heads of states commit to? Globally, they committed to successfully treating 3.5 million children with TB by 2022. That is next year. But each country was allocated targets which we needed to meet. So for Kenya, they're supposed to diagnose and treat 68,800 children by 2022. And for TB prevention therapy for children under 5, we are supposed to have done 130,850 children. Next. Yeah, we also had commitments on drug-resistant children, the drug resistance among children, where the heads of state committed to treat 115,000 children with drug-resistant TB by 2022. For Kenya, our target was 664 children by 2020. Next. And the other one was on prevention. The number of children that were supposed to have been put on prevention by 2022. And globally, the figure was 24 million. And in the previous slide, we have looked at how many, the proportion Kenya was apportioned. Next. Okay, yeah, that's a summary of the targets, which I have alluded to earlier. Next. So I think now the most important section of this presentation is where are the opportunities for the communities to engage in advocacy around access to this technology. One, the communities and civil society have a very important platform where they have been represented, or they have been given opportunities for representation in major decision-making processes. For example, the TBICC, the KCM, and also in the processes of making development of national policy documents. For example, the national strategic plans for tuberculosis. And these are very good opportunities where the civil society can plug in and push for some of these gaps that we have seen. Number two, we have the opportunity for building community linkages and collaboration between other sectors to improve on access. And of course, advocacy for utilization of available technology. I'm going to talk about what the technologies that are available for communities for advocacy. It's like, next. Another opportunity we have is that early this year, the network of TB champions launched what is called the Youth for TB Initiative. This is a movement of youth in Kenya with the goal of advocacy for TB on behalf of adolescents and young persons. Again, this is a very crucial platform that can be used for advocacy, but of course it comes with its own gaps about support, which is a huge gap for them to deliver on the goals and mandates. Next. Yeah, this was discussed in the breakout meeting forum that we had early this morning. An opportunity for engaging the Ministry of Education to sensitize the teaching fraternity on the issues of TB and TB HIV among children. And this is one example where we sensitized teachers in one sub-county in Kiambu about issues of TB and TB HIV in children. Next. Yeah, the TB HIV community also has a very crucial role in creating awareness. We have a role to do creating awareness to the public about the new technologies that we have listed, because for demand creation about technologies, the demand has to come from the communities, and the communities cannot demand if they have not been sensitized. And who can do this? It is the communities and the civil society. We have the role of disseminating the new policies to the community. We also have the role of being the gatekeepers in relation to human rights, to ensure that in the delivery or even in the lack of access, because lack of access is a human rights issue. So the communities have the role of advocating to remove those human rights barriers, and promotion of use of existing technologies and social media platforms, and technology available for community-based monitoring. We have one technology that has been developed by AMREF through Global Fund. It's called iMonitor. iMonitor is a platform it's an app that can be downloaded on the phone, and the communities are able to pick up issues at the community level and give feedback to a central place, and somebody picks up the issues and addresses them. This includes if there's a stock out of any stock out for children related response, and also other TB issues, not just for children. Yeah, so there's that iMonitor, and there's also one impact which still we don't have in Kenya, but it's in use in other countries, for example, Tanzania, which you can also adopt. Next. Yeah, community mobilization. Of course, the communities have the responsibility of community mobilization around TB and HIV children issues, doing case finding, contact tracing, and also doing support for treatment among children. And again, that's another example of the TB champions doing their work, doing community mobilization in one of the counties. Next. Yeah, the role of advocacy, of course, we know very well communities are very strong in advocacy. And this is just an example of one of the communities doing advocacy for uptake of TB prevention therapy. This is Pamoja TB group in Kangemi doing advocacy for uptake for TB prevention therapy among children. Next. Yeah, community-based monitoring. Like I mentioned, communities have the linkage between the public and the service delivery, and the policy makers. This is just one example of how the communities have been able to bring out the stock out or the issues relating to children at the community level. This is somebody who picked an issue of a stock out, which he felt needed urgent response. And through just a WhatsApp message, we are able to follow that up and ensure that the issue is addressed. Next. Yeah, again, the role of advocacy, the issue of advocacy, we have been engaging the political leadership in ensuring that children issues are addressed. This is an example of an advocacy that the TB communities did early this year when there was a reported stock out of TB treatment at some of the counties. And what the communities did was to do a letter to the Cabinet Secretary of Health, listing the issues that were there, and it included the stockouts, and this was addressed. So yeah, again, the community have that responsibility to engage the political leadership in advocacy. Next. Yeah, so what are the challenges that communities have faced and what are the recommendations we have? These are not exhaustive, of course. I know as we go into the groups, more will come up. One, there's an inadequate support to communities to engage in childhood TB and HIV issues. There's also inadequate capacity in understanding those technologies. There are gaps in data to support communities' contribution. Access to data has been a very big issue, and this data is required to inform advocacy and even community interventions, but it's very difficult to access that data. There's limited investments and initiatives towards community initiatives for children. And again, I've talked about access to data to inform advocacy. So what would we recommend? One, we need support to community. Sorry about that. If communities are not informed about this technology and the technologies have come up or the guidelines, then how are they able to do even community engagement around that technology? We also need to have improved linkages to devolved units to enhance data capture and monitoring at the community level. Next. Yeah, those are some of the challenges and recommendations that we have been able to come up with. But I believe at the group level, at the group discussion, we are going to come up with more and more recommendations. With that, thank you so much. And I hand over back to my co-moderator, Dr. Obiti.
Thanks a lot, Eve, for walking us through that bit of the community participation, community representation, and for highlighting those bits, which we even continue to discuss in our various plenaries. So a snapshot of what you've just taken us through. You started by listing the available technologies for diagnosis of TB, which also apply to children. Went ahead to discuss the gaps in access to these technologies with more focus or more bias towards the pediatric, and we were all able to appreciate those particular challenges. You pointed out one key aspect of post-TB care for children, which is needed. You also took us through the UNLHLM targets for TB, the global targets, and which Kenya also has a share of its own, which also cover treatment for TB, the usual drug-sensitive TB, drug-resistant TB, and also TB prevention. Then towards the end, you also took us through the opportunities for advocacy, for demand creation, for better technologies for the pediatric population. Then you also gave us a highlight of some of the community actions, some of the community initiatives which are currently ongoing, Youth for TB initiative and many others, and the roles of communities and the challenges which are faced by the communities in terms of trying to access and trying to create more demand for this. Thanks a lot for that. Now I move to the next presenter, the third presenter of the day, who's Dr. Stephen Wanjala. So Dr. Wanjala is an implementation scientist with over 10 years of experience in large-scale program implementation, epidemiological and clinical research, and also service delivery in Kenya. He's passionate about solving public health and clinical problems that afflict lower and middle-income countries. He has a special interest in eradicating tuberculosis, drug-resistant tuberculosis, and HIV from Africa and the world. He is currently the pediatric TB focal person in the country. I mean, wherever he's working, and also plays a key role in the community of experts in the pediatric TB community of experts. He is the Deputy Chief of Party of the USAID-funded TB Act 2 program at Center for Health Solutions. He's worked in multiple organizations, including UNICEF, before coming to his current position. Otherwise, I give you this opportunity to take us through the next bit of presentation, which deals with innovation, leadership, and governance with regards to diagnosis and access to technology for the pediatric TB population. Over to you, Doc.
Thank you very much, Dr. Witi, for that kind introduction. And thank you to my co-presenters, Dr. Kisia and Evelyn Kibuti, who we work very closely with around issues related to TB and pediatric TB. So I'll be taking us through a short reflection, really, on the role of leadership and governance in driving innovations for TB and TB HIV diagnosis and data management for children. Next slide, please. So I've divided my presentation into two big blocks. So the first block is going to be looking at diagnostics, and the second is going to be looking at data. And in each of these blocks, I'll give a summary of the problem and some of the reasons behind the basis, or the reasons behind the problem. Then I'll use that as a springboard to an idealistic sort of reflection on what would be the ideal for either diagnosis or for data for TB. Then I'll summarize at the end or wrap up this by having a short reflection on the role that leadership can play in driving innovations in childhood TB and TB HIV programming. Next slide, please. So I think we can start here. I skipped all the numbers because these have been very ably presented by Dr. Kisia earlier, and I'll make reference to some of those numbers. But I think this roadmap I draw from the World TB report, actually from the pediatric roadmap, global pediatric roadmap, is a clear indication of just how much we've been focusing on childhood TB. So in 2011, there was a call to action, and around 2012, there was a meeting in Sweden that came up with the first set of global burden estimates for childhood TB. And then after that, we had several consultations, and in 2013, we had this roadmap to for childhood TB towards zero deaths. Now, after that, there have been several forums where I've been discussing childhood TB and TB HIV, and DRTB at a global level. And you can see on the right of your screen how the numbers for childhood TB have changed over the same period. That you can see below or before 2010, the numbers were in the lower, below 200,000 across the globe. But then after that, after there was a shift of focus, having childhood specific targets for childhood TB, having several forums to discuss, putting together or disaggregating data to more granular age groups for childhood TB. Then after that, there was an exponential growth in the number of cases of childhood TB that were reported at a global level, actually more than twice, hitting the over 400,000 mark. So what is really more telling for me from this roadmap is that before 2011, where we didn't even have childhood TB targets, TB is one of the oldest diseases in the world, but yet before 2011, we did not granulate childhood TB issues as much as we have, at least from 2019. Next slide, please. So where then did we go wrong? Where did we leave our children behind? And it starts, I think, from research. As a researcher, I know that very often we forget children, to include children in our research design stage. And this is because, of course, there are more stringent regulatory frameworks around including children. So it's more trouble for the researcher to include children. And this comes at a cost. It means that whenever we have innovations, children will be thought about last. There will be an afterthought after we put all the adults through studies, then we'll think, okay, so how can we deal with the children? Especially for problems where the magnitude in adult is considered bigger than that in children. So even when we go past that stage, we jump from the research stage and we go into an implementation phase, we still have great delays in adopting those technologies that have been proven or shown to work in children for actual use in implementation. So we'll see, for example, the chest X-ray or the use of artificial intelligence in interpreting chest X-rays is really growing among adults. And this is an exciting field for many people, has been scaled up in many countries in Asia, and many other places. But then this scale up has really focused as well on adults in most of the places. So you can see that if you pick literally any technology, or at least 90% of them, you would see that children always lag behind in being beneficiaries or accessing these technologies for diagnosis. Then even when we do adopt them and we deploy them in the field, we still have lower uptake of these diagnostic technologies among the pediatric population. As Dr. Kise mentioned, last year we had just over 5,600 childhood TB cases notified, which was a 30% drop from the previous year. And she also showed a trend from 2015 where we've been more or less consistently dropping on average. There have been years when we've increased, there are years when we've dropped, but there was a big drop last year of about 30%. Interestingly, only 39% of the children had a gene expert, and only 56% of the children had a chest X-ray, with half of this being normal. So it's clear, and if you go across countries and even counties in Kenya, you see that this trend is consistent, where we have a technology that is available, which of course children, there was a delay in access generally for that technology to children, but even where that technology is available, that there is still a lower uptake in the pediatric population. Next slide, please. So because of that initial point I mentioned, where at research point we are always designing tools that are targeting adults mostly, we end up with tools that are less than optimal when it comes to diagnosis for children. So even where they're able to access, then because of the several issues which I'll touch on later, these tools, the performance of the tools is often less than optimal. The chest X-ray AI algorithms, which are being scaled up and might be really useful for low and middle income countries like Kenya, have been trained. The AI technology has been trained to really read X-rays from adults. And so X-rays from children perform much poorer in that algorithm. GeneXpert as well, in terms of, because of the challenges accessing sputum, the performance of GeneXpert is not the same as in adults as it is in children, because it was designed for sputum sample, which is not largely accessible sample among children, particularly those in the lower age groups. The result of this is that across the globe, as Dr. Kisia pointed out, we only reach about 30% of the estimated cases globally. So there is a big gap, and we have to think creatively around this, from both basic science level to implementation level to community level, and how to facilitate planning. How do we plan and set up our programs to be able to innovatively get around this big challenge of missing up to 70% of the child with TB cases? Next slide, please. Next slide, please. So I think it's important, if we're thinking about innovating, to ask ourselves, so what's the reason? What's the reason behind this big miss, this big gap? Because if we ask ourselves and what's the reason, then from the challenges is where we can find opportunities for innovation. And both Dr. Kisia and Evelyn have very ably highlighted some of the challenges. Pardon me for repeating some of them here, but I think they are very good springboard for innovative thinking. Because if we do not have a problem, then we cannot think innovatively around it. So there are a whole lot of reasons, and I just list a few. This list is not exhaustive, but they range from biologic to operational. And from a biologic perspective, we know that childhood TB is bacillary in nature. We also know that the syndromes, the clinical syndromes for childhood TB are varied, much less specific than the clinical syndromes for TB among adults. So a child with TB might just present with recurrent pneumonia, and because we, as Kenyans, maybe have a tendency to hop from one facility to the next, they might present with a pneumonia-like episode in facility A today, jump to facility B with a pneumonia-like episode in 2 weeks, and facility C, and the history is lost in that facility hopping, or even going to the same facility and seeing somebody completely different. And because of our challenges with record keeping, they are not able to catch that pattern and say, this could be TB. So that non-specificity of childhood TB syndrome makes it much more difficult to diagnose. And then we work with less than ideal specimens for our current technology. And from an operational perspective, there are policy gaps, with gaps in political will, looking at the global example, where we only started really focusing on childhood TB in the last decade. And also looking at, for example, if we look at our national reports, our disaggregation or analysis of adult TB data is usually much more deeper than that of childhood TB. Then we have regulatory challenges. I know I worked with a group from various organizations to try and get GeneXpert EID and viral load in the country. And there are several group people involved, CHAI, ECPAF, Kenry, other people in a research consortium. And there was one of the challenges I noted from this was significant, hoops that need to be jumped by researchers or companies or other people trying to bring in new technology. So even if a technology is tried, tested, and proven with multiple studies. It still has to go through quite rigorous and maybe unnecessarily bureaucratic, or maybe let me just say rather inefficient process of being adopted in the country. And that could be one of the areas that we focus on as policy leaders, to smoothen and oil that process, that when we have a good technology out there for our children, we are able to get it quickly and deploy it quickly in our programs. And then Dr. Kisia had a very good cascade, service delivery cascade, which touched also on the community level, where we have missed opportunities at various service delivery points. And we have to think around this innovatively. How can we come up with programs that are more tailored to address our childhood TB problems? Then we in programs all have a tendency to think vertically, and we have to challenge ourselves to think beyond TB. How do we collaborate with the HIV program? How do we collaborate with the nutrition program? How do we collaborate with the childhood or child welfare programs to really optimize access and think of the patient being at the center, so that our programs are more patient-centric rather than verticalized, so that we are able to integrate more. Then, unfortunately, in terms of innovation, especially in basic sciences, from a commercial perspective, people or companies always think about, if I put a product into market, is it going to be a sustainable product? I know a couple of years ago, we had at a global level, there was discussions around the stopping of manufacturing of TB lamb. And that was mainly because of the fact that the manufacturers did not think this is a big enough market. And the childhood TB cases, because of underreporting and many other things, the true burden of childhood TB cases has not been really appreciated. And therefore, it does not look like an good incentive for industry generally to invest in technology to innovate around childhood TB. So this means that we have to find other frameworks to drive this innovation at that level, driving the development of more tools that are more adapted. So we have to think about different mechanisms rather than market-based mechanisms to drive that innovation. So next slide. So then these challenges lead me to a sort of reflection on what I would call my ideal world for childhood TB diagnosis. And in my ideal world, I think we would have affordable, simple, robust screening and diagnostic tests which have optimal sensitivity and specificity. A test that I can easily deploy to Wajir or Turkana, and it's not going to need maybe a lot of electricity. It's not going to be sensitive to dust like maybe Gene Expert would be. It's not. So that is easy also for the health worker to use. That way I'll be able to provide access to every child. In my ideal world also, children would present with classic clinical syndromes. I know this is really dreaming, but it's good to dream, because then that way we challenge ourselves to think, okay, how can we get around this problem? We would have easily accessible specimen for the diagnosis of TB. We would have health workers who have a very high index of suspicion. And we would have, program managers who are able to craft efficient service delivery models where we don't miss any child in those service delivery models. So good patient flows, well integrated across departments, and you are unable to miss patients. Basically, we miss very few. And then once we get them in that diagnostic process, that we would have a perfect transition, from treatment, from diagnosis to treatment for all those who are confirmed. So then we'll be able to move from the 17% bacteriologically confirmed, which is a good improvement compared to 2015, as Dr. Kisia presented. We'll be able to move from that 17% to a higher percent, and we'll also be able to meet the targets which Evelyn mentioned. So like last year, we were supposed to notify around 15,000 children. We only notified around 5,600, which is about 10,100 short of our target. Next slide, please. So I think the question that we have to ask ourselves when we are looking at the ideal world is, where do we have room to innovate? In that ideal world, we have what we have today, and then we have an ideal world on the other end. And we have to ask ourselves the question, where do we have the room to innovate across this domain? Is there room for us to have more affordable, simple, robust tests? Is there room for us to have a better understanding for the clinical syndrome amongst our healthcare workers? Is there room for us to explore the specimens that currently exist and even other specimens? Next slide, please. So I think the general answer to this question is that there is room across nearly all those domains. There is room for us to think about better tests for children. There's also, before we even go to better tests, there's room for us to think of how we can better deploy the current technology, which Evelyn very ably listed, to improve access by our children. There is room to better understand the clinical syndrome of childhood TB. And right now, AI is developing at an unprecedented pace, and we have the opportunity to train AI better to be able to provide that decision assistance to our clinicians and even our programmers. There is room to innovate around how do we deliver capacity to our healthcare workers, and how do we design programs or service delivery models that are innovative, efficient, effective, and responsive to the needs of children, so that we're able to screen those who are most at risk, to thoroughly evaluate them, and once we have a diagnosis, to ensure that there is perfect linkage to care for those who have been diagnosed. Next slide, please. So I will move, before I go to the reflection on leadership, I will jump over to the next theme in my presentation, which is on the data. And I will call back to our minds the roadmap that I presented, where it's only in this last decade where we've had a bit of a focus on childhood TB cases. But even then, we still don't have a clear understanding of the true burden of childhood TB. And we know that for any epidemiological response or programming response to be effective, there has to be a good understanding of the burden. Then one other big problem with our data for childhood TB is that for a long time, we've not disaggregated data. I think the HIV world moved a little bit faster than the TB world in this regard, that it's more than a decade, I think, since the HIV world data started being disaggregated among children below 15 years. But it's only in 2019 that at a global level, for the first time, data for childhood TB was disaggregated along the ages 0 to 4, 5 to 9, and 10 to 14. Before that, there was, I think, disaggregation 0 to 4, and then 5 to 14. And before that, all of them were lumped as 0 to 14. So if you remember Dr. Kisia's presentation, she talked about, I think about 50% of our childhood TB cases being in the age group 0 to 4. And what does this tell us? Does it really mean that the burden of TB is much lower in the ages 5 to 14? Or does it mean that we are missing more children in the age 5 to 14? And if we look at data from, flagship projects like the CAP-TB project by EGPAF, the TB Reach, I think we have 7 by CHS, and many other projects that have had specific focus on childhood TB, we see that cases are there. It is that we are missing cases. So the patterns of data, that the level of disaggregation that we give data has a big impact on how we think around the strategies to reach the different cases in the different subgroups, and how to adapt our programs and service delivery to be able to close the gaps in detecting cases in the different subgroups. And because we do have a limited understanding of the burden of childhood TB, we very much end up with many cases of underreporting of childhood TB cases because these cases are missed. Then lastly, we very often, our depth of analysis for children is limited when we compare this to adults. And that means that we spend less time reflecting on the root causes of, one, why are we getting, why are we not getting the cases that we're supposed to get? And also, why are our programs not adapted to the specific populations? Next. So what then are the reasons behind these gaps in data? And for a long time, pediatric TB has stayed in the shadows at a global level and even national level. So there's not been a big political will around putting in the structures, the reporting structures around pediatric TB until recently. And that goes also with the lack of global frameworks for reporting. But now, at least from 2019, there's a disaggregation that will enable the world to really reflect in a deeper way on the problem of childhood TB. Then the data that we have at hand, we don't analyze it as much and don't use it for operational research. And this is linked to the lack of capacity, or even just dedicating a specific role to look at operational research with pediatric or childhood TB as a key focus area for this kind of role. Then we have the typical system problems with data, failure in documentation by healthcare workers, which we can strengthen through interventions such as BQAs. Next slide, please. So in my ideal world, for childhood TB data, we would have one electronic system that uniquely tracks a patient from birth. And in this system, we would link demographic, social, economic, or biological data that helps us to be able even to predict, this child has malnutrition, or this child is coming from a household that is food insecure, and therefore they would probably be more likely to have or develop TB, and therefore would be able to tailor our screening based on this background risk information. And we'll take also a fight of TB from just being a curative program to also a big focus on prevention. Then we would have in that system automated routine appointments, integrated screening, would have perfect documentation of encounters with error checks, which are assisted by AI, which also plays a role in decision assistance for the healthcare workers. Because we would have a perfect system, we would have minimal loss to follow up due to transfers, and you would have AI assistance to help with quality of care. So, for example, use of digital adherence tools integrated into that system. Then we would need spend less time generating reports because we would have automated facility, subnational and national reports and dashboards. And dashboards which would be conveying information to programmers and to clinicians and even community providers that would enable much swifter action that is data-driven. And then we would integrate a strong component of operational research using harnessing the power that AI is giving us to be able to process big data. Next slide, please. So then what can we do to get closer to that ideal in terms of data? We can, I know we have TIBU at national level, we have the HIV systems. We can consolidate and enrich existing systems in terms of HB disaggregation, ensuring better communication between systems, building in data analysis automation, building in dashboards to better help programming at subnational, national, and national level. Will enrich the variables that we collect to be able to help us with some of the predictive analytics and really harness the power that AI can really give us. Then we would expand the tools that we have currently from just being surveillance and documentation tools to being really patient-centric service delivery tools that are able to help the service provider, for example, make sure every child has a screening at the child welfare clinic, a screening for TB at the child welfare clinic. Then we can strengthen the inbuilt data quality checks and also harness the power of AI for automated reporting. And lastly, we would strengthen research on childhood TB so that we are able to really reflect on the root causes of our problem and think innovatively of how we adapt our programming. Next slide, please. So for both diagnostics and data, what is then the role that leadership plays to be able to drive that innovation that is needed for these two domains of diagnosis and data for childhood TB? One is that we need leaders to provide the vision. So we need vision at global, regional, country, and subnational level to have clear roadmaps around TB and childhood TB, including innovative ways to harness the power of AI in in diagnosis, in collection, synthesis, and use of data. Two, we need leaders to rally effectively, build collaborations between industry, pharmaceutical, biomedical, pharmaceutical, academic, industry, and implementers, so that we get the right people interested in this problem and we have specific groups focusing on specific problems that they can solve. Then resourcing, where we get governments, development partners, and here I want to mention specifically even county governments to put in the necessary dollars to be able to build the human resource and infrastructure that is really needed to solve the issue around childhood TB. Next slide, please. Then the other role would be driving. Once we have all this resource together to manage, the teams to be able to prioritize and solve challenging problems, develop innovative solutions around the problem of childhood TB. and being able to create the necessary environment for creativity to thrive. So, for example, we've had lots of global challenges around several public health problems. I think we need to put childhood TB issues and TB HIV issues into this kind of environments that drive innovation or innovative thinking. And then lastly is accountability. Now, we need to hold ourselves accountable. And I'm very happy that Evelyn, even in this meeting, is holding us accountable as a country to the commitments that we made as a country. We said, for example, we will be able to detect 15,700 cases of TB last year. That is childhood TB, but we were only able to detect 5,600 cases. We have to ask ourselves why, and be transparent to ourselves around what are the real challenges behind this. So, because I think anyway that if you have to get to the moon, we have to dream big, and then think about how do we build then the rocket that will get us to the moon. And I think it's really time that we dream big around innovation and leadership around childhood TB without forgetting the technology that already exists and deploying that efficiently and effectively. Next slide. Thank you all.
Thank you, Dr. Wanjala, for that. Such a thought-provoking, reflective, and inspiring few minutes which you've had with you. And without attempting to water down what you've essentially taken us through, I'll just summarize it as thus, that you've walked us through the global roadmap, reviewing it all the way, presenting a time series all the way from 2011 up to 2020. You capped something as where we left our children, and you've taken us through that in terms of diagnosis, in terms of diagnostics, and also in terms of TB data, where you are able to point to us the gaps, you're able to point to us the reasons as to why we left our children behind. You pointed us to the ideal world, which we should aim towards. You also pointed us to what we needed to do to get closer to this ideal world in both diagnostics and TB data. Lastly, you took us through the role of leadership in both diagnostic and data in relation to childhood TB, informing us that we needed visioning, we needed rallying, we needed resourcing, we needed driving. Lastly, we needed accounting or accountability to our consumers and the community. Otherwise, thanks so much to all the three presenters. As I hand over to my co-moderator to tell us the next session, I am your co-moderator, Dr. Philip Owiti, serving as a technical advisor to the National TB Program. Eve, back to you.
Thank you so much, Dr. Owiti, and to all the presenters. It feels to me like we were in the shamba, in the farm, harvesting potatoes, leaves, maize, to come and prepare a meal. Now we are breaking down to our kitchens to go and prepare what we have gathered from the farm of the presentations that we have just received. So at this moment, we're going to break into our groups, which I call our kitchen, where we are going to go and discuss several issues basing on the information that we have received from the presentations that were made. And then we shall come back and serve the meals that we have made in the groups. So we're going to, we have three groups. Group one will be on service delivery, which will be chaired by Dr. Kisia, and the rapporteur will be Catherine Macho. The second group will be chaired by me, and the rapporteur will be Jean Wanjiro. And the third one will be chaired by Dr. Wanjala, and the rapporteur will be Joyce Ouma. We have about 45 minutes for this discussion. And because we don't have, the technology is not on our side today, so we are not able to do the automatic allocation of groups. Once the groups are open, the breakaway rooms, select the specific area of focus that you feel you want to go, and just join that group. I'm hoping that naturally we are going to have equal distribution, because we may not have control of what groups people choose. We just hope we don't get a group that will have no people. So let's have the breakaway rooms open. It's now 12:43. If we give ourselves 45 minutes, or we can do this with less. I believe we can do that with 30 minutes and get back after about 30 minutes. Let's see how much we can do in 30 minutes. Thank you. Let's select our groups. I hope we can all see our names. You just look at the list and join the group where your interest may be. Yeah, you should be able to see on your screen a list. Sorry. Admin, are you able to bring the lists with the different groups? Have them displayed on the screen and let people select the areas that they want to go to. Admin, you can offer additional support to ensure that people get into the rooms.
Good. Thank you all. I hope you enjoyed your sessions, despite the short minutes which we gave you. We are now going to go into another brief session of getting some, sorry, just a minute. I think there's some echo from my end. Let me just close one device. Okay, we are going to go into the next session where we are going to get short presentations from each of the groups. We have 3 groups, one on service delivery, the next one on community response, and the third one on innovations, leadership, and governance. So group 1, are you ready? Takisia, is your group ready? Okay, and the other groups, we also just prepare yourself. We might call on any of you. All right, so I think I'm still not able to get any response from the first group. As we are waiting, maybe let's move to group 2 on community response. Just a brief highlight on some of the bits which you are able to discuss in your particular group.
Thank you, Dr. Witty. I will give a summary of what we discussed. My rapporteur had technical challenges, so I will do a bit of it, and then she will bring what she was able to gather when she was able to join. So on the issue of data, and I hope you can hear me. Wherever I am, it's a bit noisy. Can you hear me?
Yes, I think continue, although it's some difficulty, but please continue.
Okay. So first is quality, for quality data with regard to TB in children. The issue is we need quality data in regard to TB in children. The communities do not have the capacity to gather that data. And therefore the recommendation is that we need to give the communities tools that they can use to gather data from the communities, and these tools should be easy to use, community-friendly tools for data collection. Then how do we okay. Then the second issue was how do we bring out children in schools? Yes. How do we bring the human face of TB and HIV among children? Because we have been talking about data in terms of figures, but we need to bring out the actual stories, the ones that will be able to bring the emotions out of us as we make decisions. We need to get champions for TB and HIV, for pediatric TB and HIV, and this should be champions at high level who will rally for the children. On the use of updated technology, the youth in the group said the youth have a lot of capacity to come up with updated technology. They're able to use artificial intelligence, for example, to support innovations. But the challenge is they are not being supported to do that. So the question they ask is support young people to use their capacity to come up with innovations that can support uptake of technology. The other one is support champions. Again, the youth who are able to develop applications, software that can support in TB, HIV, pediatric response, but they need support. We need to do exchange visits from institutions that have succeeded in technology uptake, or where communities have been engaged in technology issues, that is peer learning. build capacities of data interpretation among young people, because it is not difficult. It's difficult to just interpret data as it's presented from, for example, from the government. Teach the youth on how to interpret that data so that they can use it. Again, the communities need to be educated on upcoming technology, so that when you tell them there's a new technology called TrueNut, let them be educated on what is TrueNut so they can be able to push for demand creation from the communities. The education in TB and HIV should be intentional from the community level and the family level. Let's promote prevention at that level. Let's TB has been medicalized. Let's simplify TB so that we can have communities being able to do advocacy and community engagement. Strengthen referrals and linkages so that the services that are not available in one site can be referred. And finally, build more advocates around TB issues, and not necessarily those people who have had TB, but strong advocates who are able to break down the science of TB and sensitize the communities around that. And yes, I think in summary, that's what I've been able to gather. I don't know if Jane, you have anything to add? Welcome, Jane Wanjiru. Jane?
Jen, if you have anything, just lift up your hand. When unable to unmute yourself, we'll be able to unmute you. Okay, as we await Jen, I see
Okay, thank you. I'm going to make my presentation on behalf of Group 1, where we were trying to look at the issue of optimizing accessibility and accountability of service delivery.
Okay, Catherine?
Yes.
Just allow me to cut you short just before
Yes.
you present, because it looks like you're going to present for Group 1.
Yes.
Let's get some two hands to talk about what has been summarized by Group 2. Then you'll come in next to present for Group 1. So apologies for that. So let's have Joyce Ouma. Unmute yourself and go ahead. Okay, Joyce. Okay, meanwhile, let's have Jen Wanjiru.
Hello.
Yes, please go ahead.
Speak.
Yes, Jen, we can hear you. Go ahead.
There was a concern from the members that we need to have exchange of programs and activities, and also partners doing mentorship to the CSOs so that they can be able to streamline what might be weak. There was also another issue of empowering the young champions, promoting building capacity for them to enhance access to data. The other one was the engagement of CSOs in contact tracing, referrals, and follow-ups. The other one was about empowering the community to access data and capacity build the community, even in matters of advocacy. I think that is my additional to what Evelyn has just presented. Thank you.
Thank you very much. Is there any last response to this team before we move to the next? At auction points, they usually say going once, going twice. Somehow we never reach going thrice, but Anyway, thanks a lot, Group 2. Let's have Group 1 presenting, and it was Catherine, right?
Yes, thank you very much, Chair. This is Group 1, and we were looking at how the issues with regard to accessibility and accountability of service delivery in promotion of equitable access to technology for diagnosis of TB and HIV in children. So we had a number of issues that came up. Some of the issues had to do with access to gene expert services. We felt that majority of the children or the caregivers are unable to access these services. And there's need, therefore, to decentralize these machines to lower facility levels so that we can be able to have children access these services. And we are saying that they should also not just be, people should not just focus on public facilities, but also faith-based facilities so that they can be able to access these services there as well. We are also saying that we need to be able to link the patients to these health facilities, even if it means being able to use public resources like Boda Boda so that they can be able to access the services. We are also concerned that there is too much reliance on the government, and we are thinking that we could do better if we establish partnerships with the private sectors as well as the faith-based sectors so that it becomes necessary that children can be able to access these gene experts at the nearest facilities and use maybe under the cover of NHIF so that it is important that the children get the service at them in the nearest time possible. We also say that with the introduction of the stool as a diagnosis way of, we need training for healthcare workers so that they can be able to use this or this method to diagnose the TB. We are also saying that there is need for capacity building, mentorship of healthcare workers so that even as we train them, we observed that sometimes there's a lot that is spent on training the healthcare workers, and sometimes they are just taken to other service areas, and then we lose out, having trained them, having spent so much training them. So it's important that we are able to ensure that when we capacity build, we actually benefit from this by ensuring that the healthcare, the people we have trained actually are utilizing the skills that we have empowered them with. There was also the issue of transportation of specimens, whereby sometimes there are delays and it compromises the quality or the sample integrity. And we are saying that it's important that we strengthen this so that we ensure that the specimens actually give us the results that are expected. We are also hoping for adequate funding. We noticed that there was little funding allocation for acquisition as well as maintenance of the machines. We are saying that this would be important that if we enhance or lobby for more funding in this particular area, even though we realize that sometimes because of the disconnect, especially at county levels, you find that even though the funds have been provided, the machines have been provided, there is confusion, and as a result, you find that we are not able to benefit 100% because there's breakdown in communication. Then we are also, it's important that we look at the socioeconomic status of the communities that we are trying to reach out to. Some of them after you have established that they need to bring their children for diagnosis, some of them may not be able to come, not because they don't see the need to, but because they are not economically empowered, in the sense that they are unable to come to the health facilities because they don't have the resources. So I think that is what I have captured. Maybe Dr. Kisia, if you are there, maybe you can add some more. Thank you, or any other participants. Thank you.
Hello, is there any additional point for that group?
No, I think she covered everything. Thank you.
Okay, thank you so much. We have one more group to go, that's group 3. Group 3.
Thank you very much. I'm sorry, I was still trying to unmute myself. Can you hear me?
Yes, we can hear you loud and clear.
Okay. So for group 3, we were looking at innovations, leadership, and governance to promote equitable access to technology for diagnosis of TB and TB-HIV co-infection in children, and also looking at effective data management. And the main points of what were the urgent issues that we highlighted were that we have parallel operations between related programs, that is the TB and HIV programs. We also have very parallel commodity focusing, planning and procurement. We are also working on programs differently and solving issues separately. So basically we have programs, TB and HIV programs, that are working in silos. We also have lack of commodity, basically around commodity security. And we also had a mention of decreasing funding or declining resources in terms of TB, HIV programs, especially pediatric programs. We also had lack of community feedback mechanisms. Going forward to the suggested actions and solutions offered in order to address the challenges that we have highlighted above. Our overall solution or proposed solution was to deliberately synergize our efforts to merge the existing silos in the HIV and TB programs. So we talked about having common accountability frameworks. For instance, the TB program was mentioned to have excellent structures. The CTLCs were mentioned to have certain good work structures in that they collected data and generated data and coordinated at community level. And yes, so we mentioned that we should be more intentional in terms of consultations and merging the TB programs and the HIV programs. Also on the accountability framework, we have a level of collaboration by both TB and HIV programs. We need to evaluate this collaborative approach to distill lessons learned, gaps and areas of improvement, strengthening. Yeah. And also we had a mention of CASCOs and CTLCs to work together and have more integrated approaches between the two sectors. In terms of addressing commodity security, we had child responsive commodity security, where we suggest to use innovative programs that have worked, such as the Gene Experts, and use strategic negotiations by both programs to influence the pricing, basically through joint negotiations of procuring such products. We had a mention of need for a mechanism, for community feedback, to channel feedback from community, mostly at county level, whereby we have community giving feedback to the county when something is not right, like the current situation with the drug stockout. We also had a suggestion of continuous learning, whereby we would be adopting an adaptive learning approach, shift from the custom M&D that basically evaluates programs at the end, instead of all through the programs. This is in it will also prompt the community response, as I have heard the previous presenters mention. So this will be implemented through trainings and human-centered delivery, looking through frequent reviews and consultations and also project updates, but not waiting till the end of a project for us to get all these or for us to conduct M&D. We also had printing and distribution of supporting tools and service quality assessments, joint data review engagements. We also had a suggestion of programs for cross-learning across counties, whereby counties would be learning from each other through peer review mechanisms, where counties that have been successful or others that have different best practices can share with each other to improve the level or the quality of the service delivered. In terms of any specific organizations that are working on such solutions, we had examples of UNICEF. UNICEF is currently looking at supporting the Ministry of Health adolescent team, NASCOP, to develop a central repository of data, and this might possibly be linked with the situation room. We also have THS supports county activities such as data review, and this strengthens pediatric and TB HIV engagements with a dedicated agenda on the pediatrics. There was also a mention of the DHIS, HIV, TB forms, both under MOH, that may be very helpful as a starting point for merging TB HIV data at the national level. Also, in terms of data, we talked about harnessing the power of the situation room to be used by leaders to get data and to use this data and to get a clear picture of the epidemiological situation nationally and at the county level. In terms of the resources needed from other stakeholders in order to realize the actions and solutions that we have proposed above, we first of all had sort of like a quick question on, in this regard, on this situation, who are the insiders and who are the stakeholders that we are referring to. So we had suggestions of the Ministry of Education to be one of the stakeholders who are required to be very proactive, alongside the Ministry of Health in addressing issues of childhood TB, HIV. And this is above context of learning, and also look into issues such as overcrowding in the dorms and in the classrooms. And there was also a question on how do we work with school boards to address these particular concerns. Also, to inform us, the TB program has in the pipeline, they are in the process of updating the TB workplace policy, which will address the issues of overcrowding in schools. We also have an accountability framework that is currently being updated through a multi-sectoral approach. We were informed that it's also getting feedback from the HIV perspective. We also have identifying and leveraging existing platforms, such as what we have been set up, and not introducing new ones. Build this from community to sub-county to county to national, meaning we already have several existing structures that we should continue using. Actually, we should make use of. So on the accountability issue, there was a suggestion that we need to develop an inventory with a unique identification number for each client across the county and countries, so that whenever the client seeks for services anywhere within the country, then she or he will be easily tracked. And if need be, they get services anywhere within the country. And and this will make tracking easy. I don't know what we all feel about that, but yes, that was a brilliant suggestion. And we also have currently the TB program is working on a multi-sectoral accountability framework that will help in engagement of various sectors in the TB response. And we also have guidelines on the infrastructure also being key. The TB multi-sectoral accountability framework was said to be welcome, and there is need to take cognizance of integration and also, well, dig deeper into the TB HIV workplace policy. So in schools, we had a lot of conversations around schools being talked about, schools and learning institutions being talked about separately, because they have different programs, and also they are the point of where we can find most adolescents and most pediatrics actually who are at the beginning from kindergarten and all that. So in schools, there is a school health program that encompasses all the sanitation and environment issues with ventilation included. The Department of Health through school health clubs checks on ventilation to ensure that there is no congestion, overcrowding in classrooms, dormitory and dining halls. That is well taken care of by the Ministry of Health officers in order to care for in order for checks and balances in the schools and to be kept on their toes in terms of compliance. So those are some of the best practices that were mentioned, or some things that are currently going on, currently working. So in terms of any other issues that arose during our consultation, we had a strong suggestion that learning institutions should be talked about as separate entities. And we also had a concern about, when talking about school curriculum and the school policies, does this also include, does it also cater for learners up to the tertiary level, or is it just for primary school learners? I don't know if I managed to capture everything. Maybe my teammates can help, Dr. Wanjala and anyone else. Thank you.
Thank you so much, Joyce. I don't know if there's any other addition from that group. Okay. If none, and I believe Joyce has been so comprehensive, I believe she has captured everything. I was just wondering how she was able to capture that in just a few minutes that we had. I want to say thank you everybody for very, very, very constructive discussions. I particularly want to appreciate the presenters, Dr. Jackie Kisia, Dr. Wanjala, all the rapporteurs, Catherine Macho, Jane Wanjiru, Joyce Ouma, and all the participants for all your contributions, your insights, your inputs. They are very well appreciated, and I can see there are also other inputs in the chat. Thank you so much. I want to end with this statement that we are all here because we have the responsibility of our future generation in our hands. We must act now, or else the future generation will judge us harshly. With that, to thank my fellow Dr. Awiti so much, also for his support. With that, I want to we are going to go for a 5-minute break, and after that, the next session will be moderated by Francis Dwiga, Dr. Mike Ekisa, Dr. Philip Awiti, and Rudfin Bude. Thank you so much also for giving me the opportunity to be your moderator for today. Thank you, and have a very productive afternoon. Bye. I think we can have some music as we take 5 minutes break, and then we'll be back after. It's now 1:51. Then we can be back at 2. Thank you.
You know, though, sometimes it's hard to hope when problems are arising. But like a star, I'm gonna keep on shining. I'll keep the fire burning. Yeah, I'll keep on fighting. 'Cause even when it's dark and you're alone, don't ever give up. No, don't lose your hope. Just look up above. The sun is rising, a new dawn. Just keep on striving and don't lose your fighting. Even when it's dark and you're alone, don't ever give up. No, don't lose your hope. Just look up above. The sun is rising, a new dawn. Just keep on striving and don't lose your fight. Don't give up. Now, no. to change is what you see. I try to win this war, I confess. My hands are weary, I need your hand. Mighty warrior, king of the fight. No matter what, I face you by my side. When you don't move the mountains, I needed you to move. When you don't part the water, I wish I could walk through. When you don't give the answers, as I cry out to you, I will trust, I will trust, I will trust in you.
Leaders of the world, I am a Kenyan boy aged 13 years. I take this opportunity to address the leaders of the world. First and foremost, I would like you to support in improving the health systems in most hospitals. I will first point out the early infants diagnosis, which tests the infants while they are still young. If the virus is noted in the child, the treatment and the medication will start earlier and be better enough. You can also help to fund the TB diagnosis machines to help reduce the time so that the treatment can begin early. I also suggest you can help the doctors and nurses by giving them refresher courses and paying them well. Most children today have no access to medical care. This increases the chances of getting opportunistic diseases, thus increasing children's deaths. Please help get the right medications for children that they can swallow easily. Last but not least, I would like to thank you for your great step of improving the health of our world. Finally, children also need to go to school so that they may be able to live normal lives. But they also need to be comfortable in school. School should be their home away from home. They should not go to school and get bullied and discriminated or traumatized. They need people who will help them to get through it. Support in kicking out of stigma in schools. Looking forward for your continued support. Good afternoon. Good afternoon, everyone. I would like to welcome you to the last session of the day. This is a great opportunity for all of us to be able to put together the discussion for the last 2 days. And we'll be there to sum up some of the key discussion information that we have. With me, I have 4 moderators that we'll be working with. We have Dr. Mike Kisa, Dr. Philip Owiti, and Rudify Dubi. So I would like to give them an opportunity to introduce themselves to the team so that we can move together. We can start with Philip Owiti. Philip, are you there? Good afternoon. Welcome back. We actually need to start the session, and I have 4 moderators. I will request each one of the 4 moderators to introduce themselves so that we can move the program of the afternoon. I will start with
Ludfine Dubi. Rud, are you there?
Dr. Francis,
Yes.
maybe move to the next speaker. Ludfin will be with us here shortly. Sorry.
Thank you, Edwin. Is Philip there? Philip Owiti? Dr. Philip? So seems like Dr. Mike Ikesa. Is Mike there? So I think because of for the benefit of time, we'll just go straight to the session of today in the afternoon. And I think the key discussion areas would be like summing up the discussion that we had. This was a very important national dialogue meeting that we are putting together, the importance information that we really need to build conversation around how we can be able to put a smile to the face of our children in this country, and also look at how we can develop commitments that are very critical for us to prioritize children as one of our key agenda to support in terms of investment, in terms of implementation. And with that, we have other moderators that are there to take us through for the afternoon. I know there are sessions that are there, and we'll be able to share the key summary of the key actions resulting from the discussion, and also presentations of the draft action plan and the accountability framework, and also be able to have a plenary that will really moderate the reflections and input in terms of the discussion. And finally, we'll have the closing session and remarks from Dr. Kate, and finally the closing prayer. So with me, I'll now invite the key moderators of the afternoon session. In terms of the SAP, I'll invite Dr. Momanyi and Teresa to take us through the afternoon discussion. Dr. Momanyi, please.
All right, sorry guys, I was not allowed to unmute myself. Thank you, Ndwiga, for facilitating this session. So, do we have the two rapporteurs with us today? Because before we go into the action plan, we'd like to have a summary of some of the action points from the rapporteurs. Do we have the rapporteurs in the meeting? Edwin, could you just play some short video as we just confirm where the two rapporteurs are?
Okay.
Yeah.
Pediatric AIDS treatment in Africa, man. To the bata. Them a make black man so proud, man.
Yeah, people. Well, this song is dedicated to the children of Africa. We're here to say that no child should be born with HIV in Africa. And if you believe with me, rise on your feet and let's sing together. Yo, 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 yo. Children infected with HIV, some are Somalia, Morocco, Namibia, Angola, DRC. Well, ladies and gentlemen, we agreed that no child should be born with HIV in Africa. But this is only possible if we join our hands together to fight this dreaded disease. Primary prevention is a must for all of us, so each one of us must know his or her HIV status. Family planning is available, even for the HIV positive individuals. When you get pregnant and you have HIV, you can still make a choice and go to the hospitals and get antiretrovirals. If you take them well, I know that the child will be born HIV-free. Men, remember to take your wives to the hospital so that you can support them and make a joint effort to support the baby too. When we do this, we know that we shall have an HIV-free generation. Let's go! Yeah, yeah. Why, yo, 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 yo. That's why we sing. That's why we shout. Why, yo, 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 yo. Africa, we sing. Kenya, we shout. Why, yo, 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 yo. One more time. Are you ready? Yo, 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 yo. Pata, pata, we care for the children. Yeah, man.
Okay. All right, thank you everyone and welcome back to the meeting. We are very happy and pleased again to have this closing session. With us also, we are joined by Dr. Kate Ngugi, the head of NASCOP, and she shall be, of course, giving a remarks towards the end. So welcome, Daktari. So as we come to the end of this session, we first want to welcome one of our rapporteurs, Catherine Theuri, who is going to give us just a summary of some of the things that have come up from the two-day discussions. And then we shall allow for just some quick reflections on what should be presenting before we move to the next session. So welcome, Catherine.
Good afternoon, everyone.
Good afternoon.
Allow me to share my screen. I hope you can see the screen.
Yes, we can see the screen.
Okay. All right. Thank you for this opportunity. I will just go ahead and share key highlights mainly the key action areas, the key issues arising and the key action areas from the 4 sessions that we have had. The details will be in the report, but this is just the highlights. Okay, the key concern that we're dealing with in this workshop is really the issue of children and adolescents who are still becoming infected, due to unequal access to HIV and TB treatment and prevention services, poor maternal retention, and new HIV infections among the pregnant and breastfeeding women. So those are the table below is the statistics that we have been working with throughout the workshop. So in the opening remarks, we had, I just picked out some key highlights. We had the development partners, we had the government of Kenya partners, and we had the implementing partners. And what came out of that session was that there is commitment to improve quality and quantity of life for those infected and affected by HIV and TB. We need to optimize action for HIV and TB for children. It clearly came out as a gap. We are not where we need to be, so we need to optimize that. Multi-stakeholder approach was emphasized during all those presentations and discussions. There's need to engage communities. There's need to engage communities and also ensure that pediatric drugs are available. There were issues of stockouts that will be discussed and have been discussed at length during the workshop. We need to monitor results. We need to strengthen governance and coordination. And then there was the question of what unites us, what brings us together in this forum, and it's the need to end AIDS as a public health threat. That came out very strongly from Dr. Ruth Masha. An action plan must come with accountability from stakeholders. So even as we seek to develop an action plan, there must be accountability that is shared out to the different stakeholders. So that for the second session, that's when we talked about the early infant diagnosis. And we broke out into groups, and there were those three groups: the service delivery, community response, and innovations, leadership, and governance. So for that session, the service delivery raised as their urgent issues of concern as the following: the shortages of diagnostic commodities. They listed them out, some including the DBS filter papers, the test kits, the gloves, the medicines. They also raised the issue of the long turnaround time, that was the TAT, for both the early infant diagnosis and also for the viral load. They raised issues of inadequate training for healthcare workers on PMTCT, missed opportunities for HIV positive mothers who go to deliver in some facilities who are not being offered testing or infant prophylaxis. We had weak psychosocial systems, support systems for pregnant and breastfeeding mothers, hence contributing to poor adherence. And we had, when one has lost a loved one or loss of income, especially due to COVID separation, so psychosocial systems are weak, they're not working as they should. Then there's the low-skilled deliveries. That also came up as a strong point. Data gaps in the tracking of the HIV-exposed infants audit for mother-baby pair, and the lack of national HIV-exposed infant audit cohort analysis tool. So that came out as, those came out as gaps. Solutions that were suggested by this group was timely and adequate forecasting and quantification for all populations, children included. There was need, or there is need, for a work plan of distribution so that it is monitored for viral load and the early infant diagnosis, and to ensure stocks are available. So with the work plan, it's, we are able to reduce the stockouts. There's need for effective communication from the national program around availability and projection of commodities. That is the EID test kits as short-term response. The scale up of point of care facilities needs to happen, and that needs to go even to the hard to reach regions. There's need for introduction of new pediatric ART formulations, and I think there was a major discussion around this and how the ones that are currently there are not quite working because of they are bitter, they are not as if they are not measurable. They're not, the communities, the caregivers are not able to measure adequately. So there's that need, and there was good discussions around how there's an upcoming medications that will sort that out. National stock taking for determine and dual kits, as some counties are holding large commodities. So there's need for just finding out which counties have them, which counties don't have, and having a good distribution system. There was the inter-county referral, sample networking with other counties that have EID reagents, capacity building of healthcare workers, so as to do early TB diagnosis through the nasal gastric lavage. Then there's the develop, adapt a national HCA tool in support of PMTCT COE, community engagement to promote skilled delivery. Remember, that was a major issue. Facilities line list all clients who have not received TPT, and TPT is the tuberculosis preventive therapy, or not completed the TPT. Once stocks are available, all facilities need to set aside complete packs and prioritize these individuals who have not received the TPT. So those were the suggestions from that service delivery group. The community response said that stigma is still very high in children, and it needs to be addressed. And this needs to be extended to the parent and the caregiver as well. Then there was a lack of adequate engagement of the community-led responses. There was adherence of treatment for children that really there are poor adherence outcomes, and many reasons were given because of the drug being bitter, the drug, not being child-friendly. Disclosure to children needs to be done to support adherence to treatment. We had discussions of how, children are not told why they're taking the medication, and when they get to know, sometimes they get angry and, do not want to take it. So disclosure needs to be handled carefully. Ignorance and lack of adequate information on HIV, TB at the community level, and this needs to be addressed. More information, more community education needs to happen. Issues of confidentiality arose, especially for adolescents and young people who are going through a transition stage. And we remember Maureen giving us that real life scenario where she was talking about her son transitioning from childhood to teenagehood and how that all came out. So that needs to be addressed. Gaps in data utilization to form programming needs to be addressed. The community suggested the use of CHVs to follow up the community household level, the use of family-centered approaches to bridge the gaps, that is maybe through family testing, use of father mentors, and the issue of father mentors has come up over and over again, considering that we live in a patriarchal society. Then comprehensive counseling for parents and caregivers, and the need to address mental health issues such as postpartum depression, which even gets possibly even more traumatizing when the mother is, realizes that the baby has tested positive. Community-focused response needs to be strengthened, both at the county level and at the sub-county level, and using the sub-county AIDS coordinators, the paralegals, and the grassroots, the people on the grassroots, which includes even the CHVs. Empower and support for caregivers and guardians. This needs to be strengthened. Strengthening of community-led responses, such as the use of CHVs as TB ambassadors and HIV champions. Forums for engaging children also need to be created. Community mobilization and sensitization at grassroots for pregnant mothers and all those involved in care needs to happen. Empower human rights of women so that they know what services to ask for when they go to the facility. When they walk in and they're not offered, they can be able to ask because they know what they need. Peer-to-peer support for the women at community level for identification, follow-up of defaulter tracing. That needs to happen. Enhance prevention, ensure that HIV negative women are put on PrEP, and there's peer education forums that happen so that they understand why PrEP and why it's important for prevention. Addressing nutritional support and components of the babies and the component of the babies and alternative ways of breastfeeding for those mothers with a high viral load, empowering the mothers to know that they don't have to succumb all the time to probably the peer pressure of breastfeeding, that they can go into supplement feeding if their viral load is high. So just giving them the options to know and empower them to make those decisions. Strengthen community data information systems to leverage on the facility HIS. That's a health information system. For the innovations, leadership, and governance, there is need for a multi-sectoral engagement. Work with other sectors so that the Ministry of Health works with education, with transport, and any other sector that may help in the response of TB. As we have seen in the way, when COVID came and COVID was handled in a very multi-sectoral engagement way, we need to learn from that. So long distance travels to facilities, food insecurity, and being orphaned are some of the greatest causes of defaulting, leading to poor viral suppression. So these need to be addressed. If it is long distance, what can be done? If it is food insecurity, food and insecurity, and for orphans, what programs can be put in place so that that is addressed? Then prioritize the role of community and civil society innovation and leadership in pediatric HIV response. Address the stockout of commodities. This again was mentioned by the services delivery group. We no longer can afford the shortages of ARVs. And this actually is a leadership issue, because if it is not discussed at the leadership level and provided, then if there's stockouts, there's nothing that the services can do on the ground. High defaulting in faith-based community. This is the issues of faith healing that need to be addressed. Empower people with information, empower the faith sector with information, education on HIV and TB, so that they do not push the agenda of faith healing, and know where the place of faith healing in this regard, so that they don't stop their congregants from taking their medication. Still within the solutions is deliberately map out the stakeholders, know who is working where, and how can the different ones synergize around the issues of HIV, TB. Health education in learning institutions, this needs to be prioritized. We need to speak more and more and educate people through the institutions that are already set up. Social protection relating to food security and other social protection programs on TB and HIV. Financing for research and development, that needs to be scaled up. Scaling up advocacy through engagement of religious leaders. Again, here the power of religious leaders meeting their congregations on a weekly basis. How can we use that forum or those forums to help upscale, information going out to an advocacy for TB and HIV? Creating of safe spaces in places of worship. And of course, this goes with information, so that where HIV education is done without stigma. If the religious leaders are educated, empowered, then and know the place of HIV and TB and are able to give correct, informed information, then they will be able to reach their congregations without stigmatizing them. Have a common ground as faith community on faith healing messages. I think the issue of faith healing has always been an issue, and there has been discussions on how that needs to be put together and sent out, that there is a place for faith healing, but what is this place, so that they do not discourage conventional medicine. Support the response through the last mile to elimination framework, which will focus on data and help sharpen the PMTCT response in the country. So this is in the early stages, as it was said, of development. So that ended our discussions for day one. And that came, we started day two with a brief recap. The recap was given, but from the comments, I would like to highlight the comments that came from the participants this morning. The first comment we got was that having champions for children to facilitate diagnosis and care for pediatric TB diagnosis for children is very important. So we need to create champions, as children cannot go on the table and speak for themselves. We need to create champions who can be able to do that on behalf of the children. Champions need to focus on TPT to reduce rates of TB infection among children. And this needs to be really emphasized. There was also the comment that there is commitment to end HIV and TB among children. There is therefore need to leverage on political leadership and funding partners to ensure that issues around prophylaxis and treatment are addressed. And this ties up with what was in the opening remarks, that there's that commitment at the higher level, but it needs to be encouraged and it needs to be a discussion that happens often so that we keep it alive and it actually happens. The faith leadership was said to have signed MOUs with the county governments and the national government. So there is need to work with those existing structures. Again, the issue of not working in silos, but pulling together to work with the structures that are already existing for HIV, TB, and also malaria, as it was brought out in the morning. The faith sector leaders can give updates on where they are at with these MOUs and how useful they have been. I don't think we've had an opportunity to hear from the faith leaders on this, so maybe it could be one of the things that the faith leaders can tell us a bit more about. We then went into session 3, and these were the key priority areas. This is where we're talking about the support systems to mother and child to remain in the continuum of HIV prevention, treatment, and care. And again, we went into 3 groups: the service delivery, the community response, and the innovations, leadership, and governance. So the service delivery identified as urgent issues the issue of stigma and discrimination, related issues, both at school and at home, which adversely affect the retention into care and treatment. So that stigma and discrimination keeps coming up over and over again. Knowledge gap of the health providers on issues of children and young people. That was said to be lacking. So the issue of knowledge kept coming up. Then the lack of disclosure of HIV status to children. So children either get born with HIV or get infected, but they are given medication and they're not told what they're taking medication for. And this, of course, creates issues later on. Inadequate resources to adequately address issues of commodities and supplies, which supports retention into care and treatment. So again, that was raised as an issue of concern. So the solutions that the group came up with was that there needs to be capacity building of healthcare providers and continuous mentorship. It needs not to be a one-time thing, but it needs to be something that is done continuously as new information comes on board. Structured way of family engagement and support, there needs to be that. So the treatment literacy at the family level, at the community level. Commodities and supplies, we need to address the issues of stockouts of drugs and commodities such as lab reagents, so as to avoid delays in viral load testing and follow-up. And we had stories of how sometimes mothers wait for so long and they get very discouraged waiting for results. Then create linkages between school and health facility through school health programs. And this can be done through sensitization, creation of awareness of teachers and school nurses to support children adhere to treatment, even while they're in school. There was also the issue of the discussion of the multi-sectoral approach with other sectors. And again, this has come up and it had come up previously. There needs to be, we need to look at which other sectors can support the cause that we are championing, like the Ministry of Education, because of the schools and the learning institutions, the Ministry of Social Services, where we can have child protection. We can go for child protection. Multi-month dispensing for those in schools. This is like getting a system where you can be able to give drugs to children for maybe 3 months, as opposed to giving them on a monthly basis for those that are able to, for those whose adherence is good. So for schools, and to do also viral load testing during holidays to support adherence. Then there was a use of CHB and religious leaders to handle children and adolescents, and to fully equip them with information and so that they're able to do TB screening and defaulter tracing at the community and congregational level. Those were suggestions that were given, and also advocate for stigma reduction intervention and even look at which ones have worked and adapt some of those. At the community level, the issues that came up was the long turnaround time leading to missed diagnosis. There was issues of early infant diagnosis, which is still a challenge for mothers. We found that community facility linkage, that linkage is still very weak and it needs to be strengthened. We found that there was the lack or the inadequate use of CHVs who are young. There was a discussion that a lot of the CHVs are elderly people or the older generation who had been trained earlier, but we are missing out on the youth who are currently there, who can be trained as CHVs to take over and be more efficient in the community because they are more flexible on the ground and they'll be able to communicate better with the youth. Then issue of stigma, being possessed at various being the issue of stigma in schools, in churches, in mosques, in places of worship. That also came up as a concern. Poor children diagnostic procedures, that also came up. Lack of safe spaces in the community for children living with HIV, children and adolescents. Then delay in results, dissemination. I think I remember Maureen talking about how she got her son tested and 6 years later, she still hasn't got her results. Then poor male engagement. We need to engage the men more because of the society we live in. The community response suggested that there's need for establishing psychosocial support groups and safe spaces at the community level where people can go and feel safe. Strengthening community facility linkage systems to aid case tracing and community engagement. There's need to engage young people through mentorship of CHVs to aid in transitioning young people at the community level, and also to help them working with the CHVs. Establishing feedback mechanisms for quality assurance and strengthening service delivery. Those need to be strengthened at the community level. Having a client-centered approach in service delivery by continuously assessing and capacity building the service providers. And when we talk of the service providers, it's both in the facility and also the CHVs who are out in the community. There was also the solutions or the actions suggested that we need to review and strengthen the children diagnosis procedures to curb the long turnaround time. There's need to work towards adapting a multifaceted approach of service delivery at all levels of engagement. There's working with the Ministry of Education in capacity building. So you build the capacity of teachers, of the people in the schools, so that they are able to help address the issues of stigma, even as they carry out their roles of teaching. Then there's the activity, we need to actively engage fathers. I think the issue of fathers as mentors kept coming up over and over in various discussions. The Innovations Leadership and Governance Group proposed, they proposed a bill to impose, the proposed bill to impose tax on milk formula. This was brought up, and the group said that that is a challenge, because if that milk is taxed, then it will not be as affordable and as within reach for the mothers. There's need to, then there was a concern to create a national environment that fosters innovation in programming. So internationally, donors frame a problem and get support from researchers to provide a solution. So we need to adapt the same. Create a national innovation fund where scientists, researchers develop solutions in service delivery, policy issues, community response. So again, different stakeholders pulling together to look for solutions. Then there's the issue of lack of data that has come up across the board. So stakeholders need to find ways of capturing and recording correct data so that we can use it to make informed decisions. Keeping the children's agenda at the top of the minds of the politicians and the policymakers, that needs to be addressed urgently. So the suggestions and the actions, they're still around the same. So data collection tools need to be availed at the community level, but they need to be generated, and they need to be easy to use for them to be able to even use them and provide the data that is required. Then there's the tax on milk formula. There needs to be a statement from stakeholders, basically lobbying around this and championing the whole agenda and trying to stop that tax from being put on the milk formulas. Innovation fund, we need to provide letters in agreement to proposals that have been developed. How do we ensure the interests of children remain despite the transition of government? So it needs to be in policy, put into policy in such a way that even if the government of the day changes, it's there, it's ingrained in policy, so that will not change, nothing will change. We will still have the agenda standing as a key agenda. So that ended the third session. So we came to the last session, which we just had just before lunch. And this was addressing the issue of equitable access to technology for diagnosis of TB and of TB-HIV co-infection in children. Again, we broke out into the 3 different groups. And in this one, I just captured what was presented in plenary. And the service delivery group emphasized the issue of access to gene expert services, that caregivers are unable to access these services. So there needs to be a focus on the lower level facilities. Here I'm bringing out both the issue and the suggested solution besides it. There is need to link patients to these facilities. Once they're brought to the lower levels, link them to the facilities. Then there was the issue of too much reliance or over-reliance on government. There is need to build partnerships with even the private and the faith-based facilities so that all the different stakeholders synergize and support the agenda. There's training of the healthcare workers for introduction, when the introduction of stool for diagnosis is used in children, the healthcare workers need to be trained on how to do that. And then when they're trained, they need to be retained to be able to provide those specific services. There was the discussion that sometimes the healthcare workers are trained and then they're taken to other places where they're not able to use the skills that they have learned. So training them and retaining them to offer the services will help to build the agenda. Then there's transportation of specimens. There was a discussion that the delays compromise the specimens. So we need to look for a way around this so that when specimen is taken, it's not delayed and it's not compromised. Then there's little funding for acquisition and maintenance of machine. So we need to do some resource mobilization around this so that when we get the machines, we are able to also maintain them. Then look at the social economic status of the communities and support those that are not able to come because of resources. This was the discussion that you may do all the education and all the lobbying on the ground, but if they don't have the economic capacity to, probably they don't have the transportation to get to the hospital, they don't have the resources, then that needs to be considered and it needs to be thought through. The community response talked of data quality. The quality of data, communities do not have the capacity, to collect. The community needs to have their capacity built so that they are able to use the tools and they're given easy tools to use to be able to collect the data that's required. So it's the issue of making the tools easy to use and making them accessible to the community so that they're able to use them. Then bringing a human face on TB, HIV TB to children. So getting champions at the highest levels. So get champions who are able to advocate for HIV and TB to the children so that it's not just a statistic, but they are able to understand what it is. Youth have the capacity to come up with technology and they need to be supported to do so. So we have youth who are very techno-savvy and we need to build those skills and harness those skills and be able to support those skills so that they are able to serve even in this area of pediatric HIV and TB. Peer learning, carry out exchange visits to those organizations that have done well, so that organizations learn from each other, counties learn from each other, identifying programs and practices that are working and having people learn from those that are working. Then teach communities on upcoming technologies. Technology now is coming, and there's all this innovation that's coming up. Let communities learn how to use these different technologies and harness the technologies. Build strong advocates around TB, and also engage the CSOs in contact tracing. Finally, the leadership and governance group talked about, one of the weaknesses being that people are working in silos. There's parallel operations, parallel commodity forecasting, things are being done in silos. Then there was the declining resources, which also came up as a problem. And then the lack of community feedback mechanisms. So those were the urgent issues arising. Some of the suggestions that were given as actions that can be taken is that there needs to be the different organizations and the different stakeholders need to synergize efforts for TB and HIV programs, so that people are not working as silos, but people are working together and pulling together so that they're even able to optimize the resources that are available. Integrate structures. This needs to be more intentional, that people need to, use existing structures. Don't start your own structures when they are already existing structures. Find a way of harnessing the structures that are existing and working with those structures together, so that you're able to pool resources and not spending resources on something or reinventing the wheel. Accountability approach needs to be harmonized. So there needs to be a way that everybody is able to report to the central place, and it's efficient and it's working, so that everybody feels the need for using the same systems and structures. Have different stakeholders work together. I guess that's about synergy again. Mechanisms for community feedback to the county and also to the national level, that needs to be strengthened. Continuous learning as opposed to waiting to learn at the end. Put in place systems where people are constantly learning from what they're doing and not waiting for a program to end and then learning at the end of the program, so that whatever they learn as they are going on, they're able to input back to the program, making the program more efficient. Then there was the issue of printing and distributing of data tools that needs to be addressed. Cross-learning through peer review mechanisms. So learning, and in this forum, we have learned a lot from each other in programs that are working. So finding forums that people can learn from each other through these peer review mechanisms. Harnessing the power of the situation room, and learning institutions need to be engaged through school health programs. You will find that a lot of these solutions and actions are cross-cutting in the different areas, the TB, HIV, the PMTCT, in the different programs. But the community seems to be saying this, seems to be saying similar things, engage the community, use the systems, strengthen the systems. So is the service delivery is talking about strengthening, reducing stockouts, strengthening the service delivery, building the capacity of the healthcare workers. So you will find that some of these issues have been repeated over and over again. So that is what we were able to talk about in the 2 days. And there was all that emphasis in the different levels, that the service delivery has its place and brings its strength. Community response has its place and brings its strength. And there's issues of leadership and governance that need to be addressed. Thank you.
Thank you so much, Catherine, for that very comprehensive summary. I wish if it was in a physical meeting, we'll have given you a good clap for doing such a nice job and capturing all the action points and some of the resolutions, the suggestions that have been made towards improving. And I think very comprehensive. And I know, as you said, we are going to have the comprehensive report from this. And I know that some of this will actually go into the action plan. So at this point, as we are moving to the last section of the meeting, I would also like to now also introduce my co-moderator, Dr. Trisa Alwal from UNICEF. Dr. Trisa, can you say hi as we begin to moderate the last section?
Good afternoon, everyone, and thank you, Lazarus, Dr. Mamani, for this introduction. Looking forward to moderating this last session with you.
Thank you so much. And just from the summary of the action points that have been summarized and presented by Catherine, I just wanted to highlight the objectives of the meeting so that we just see if we have actually been able to meet the objectives of the meeting. And so just allow me to share my screen shortly, just a minute. So as we do that, we'd like to hear just a quick feedback from the members who are here in this meeting today. If there is any addition, any quick reaction to the what has been presented as a summary of the action points from the meeting. If there's any reflection on the same, it's a chance you can just raise up your hand and you'll be unmuted and you'll be able to give your remarks even as we come to the end of the session. So as we do that, I just wanted to give a quick reflection on the objectives of the meeting. As you know, this was a consultative meeting for 2 days. And I really want to believe that even from what has just been presented, that there's been really been a lot of consultations between the various stakeholders, the government, the development partners, implementing partners, the beneficiaries. You've heard stories from the beneficiaries, and even the faith-based organizations, and there's been very good inputs that really will find itself to the action plan. And so when we look at the meeting objectives that we had 5 objectives, and I just want to quickly run through them. So the first one was really to understand the situation and the specific challenges. And you can agree with me that from some of the presentations that have been made, I think all of us now can appreciate some of the challenges where we are as a country in terms of access to diagnosis, prophylaxis, treatment, and even prevention for TB and HIV for children. And we are all now better placed to even be able to provide solutions, because you can only provide solutions when you understand the challenges. The other objective we had was to highlight the gaps, but not just gaps, but also provide solutions. And I think from even the presentation has been done, you can see that for each of the challenges or the issues that were highlighted, we have also been able to provide solutions for each of those issues. So not just highlighting problems, but at the same time being able to provide solutions. And some of the solutions are really towards how are we able to provide optimal but also affordable pediatric HIV and TB treatment as well as diagnosis. The other objective was to really consult on how we can be able to intensify and scale up community-based responses. And from the meeting again, and from even some of the engagements and the track sessions and the feedback, you could actually see a lot of solutions that have been provided on how best we can strengthen the partnership or the linkage between the facilities and the community, because we know that for some of the issues that we have, including even the empty street rates, including some of the children who have not been diagnosed, including the TB cases we have amongst children in the community, we really need the community to come in strongly so that we can collaborate with the facilities and be able to bring these children and ensure that they are diagnosed and put on treatment. The other one was really to highlight on effective solutions and strategic partnerships that will address issues around finances, human resource, and commodities. And I think, as you've also seen from the summary that has just been made, a lot of issues have been highlighted around resources, around human resource, not just the numbers of people who need to provide services, but also capacity building issues, as well as commodities, availability, and basically security of the commodities. Because as much as we are pushing for children to be identified with TB and HIV, we need to ensure that we have the drugs and also the lab diagnosis at the facilities to ensure that it supports them while they're on treatment. And the last option, objective that we had was to develop a national action plan with clear follow-up actions, timelines, reporting, and accountability framework. And I think we shall be hearing shortly from the next presenter on what we are proposing for this action plan. And at this point, we really want to state that what we shall be presented is just a draft based on some of the discussions, but there shall be this shall need to be refined and reviewed, and at the end we shall provide some timelines as to where and when this will be finalized, but this should be immediately after this meeting. So at this point, Tris, are you seeing any hands on the chat? Anybody would like to make a point or a comment? If
Yes.
there isn't, then we can. Okay, there is.
Yes, we have Maxwell who has his hand up. Host, if you
So
can
that.
go. Maxwell, Max.
Yes, good afternoon, everyone. And just a huge sharing of gratitude to the team and everyone who's participated the last 2 days. It's been a learning experience, and just to appreciate the time and dedication under the leadership of the government, but also with the UNAIDS and UN family team coming on board, as well as the counties. With that mentioned, I think there are two key points just from the PEPFAR side that I think as we move forward, I wanted to just really appreciate and applaud these teams. Again, the 3 breakout sessions have brought it up. And I think the rapporteur did a good job in highlighting the 2 issues that I want to just raise. The first one is being the community-led community response piece. While it came out very clearly and a strong presentation from the TB team this morning, the community-led response is a very critical piece of this. And I hope Dr. Ngugi will be able to address this on how we really move towards cultivating a locally driven community response process that helps us sustain and address some of the gaps that we are looking at in terms of progress made. So I think that community-led process, there are different donors putting in money to support and strengthen those particular aspects. And so my call perhaps is to have a specific group that would then be working towards a community-led process that cuts across both these, disease areas, but also that would be emulated by other diseases not in this meeting. The second part is looking at the leadership part. I mean, the innovation of this is that I see a very good structure that already exists, with the faith sector playing a critical role and advocacy role in terms of engaging both national and county governments. Again, that question remains unanswered as we've seen it in the presentation. I'm hoping that with the leadership through Dr. Ngugi as she closes, and also from the faith sector, that we can really work again on building on those already agreed upon structures which will stand true beyond any transitions, whether within government or generations. I think that is critical because you've noted that there's a call for men, adolescents, and even younger people to be involved in mobilization and addressing some of the issues. So I believe that let us look at how we can work within those structures within the faith sector and frameworks that exist to not only strengthen the faith sector leadership's capacity, but also the other stakeholders' capacities, both state and non-state. And so I think that those two critical aspects from our point will be a very strong foundation for addressing and sustaining issues raised within this meeting the last 2 days. Thank you very much for the time, and look forward to our continued engagement. Thank you.
Thank you. Teresa, you could pick the other hands. I'm seeing some additional hands.
Okay.
Thanks, Lazarus. My name is Zilfa Samoe, working with Christian Health Association of Kenya. And I wanted to respond to the question or the issue that had been raised earlier by Max, and it has also come again in the summary report. It's true indeed that as a Kenya Faith-Based Health Services Consortium, we have an existing MOU between the faith-based community and the national government and the county governments. And we've been working along those frameworks in terms of advocacy and partnership at those levels. And it is a good advocacy tool that we are using to support even not only the public health facilities, but also our faith-based health facilities to improve service delivery and to bridge the gaps that can arise. For example, when there is an issue with a strike by the public healthcare workers, we always work together to see how can we support the services to run through the period of strike. We are currently working on a faith community initiatives program, HIV program, that is engaging men and children in terms of enabling them to seek services, trying to find them in the community, using the faith structures such as congregational messaging. So we are trying to meet them at church level in different groups like youth groups, women groups. With the challenges with COVID, we have not been able to meet a lot, but we've been meeting using social media networks, and we've had a lot of best practices that we are documenting. And as the project is coming towards the end this year, we are hoping that we will bring our stakeholders on board just to share our experiences and see how can we strengthen those structures and systems also to expand to other services in service delivery. Thank you very much.
Thank you, Zilpa, for those excellent points, and also just reminding us that there's a lot of work that has already begun. We're not working from a vacuum, and we can actually leverage on existing platforms. Thank you. Colleagues, I don't see any. I see a hand sign, a hand gesture from Dr. Kate Ngugi. Dr. would you want to respond to something? I'm not sure if your hand is up or if it was a different gesture.
Thank you, Teresa. It is in hand. I was clapping for the song that we listened from Patrick Ayaro.
Thank you. And indeed, it was a powerful song, and the clap is still on. Thank you. So, Dr. Lazarus, I think we can move to the next question.
All right. Thank you so much, Teresa, for handling that part of the discussion. So at this point, I want to welcome Charles Kibara. So Charles has been tracking also the conversation during the meeting, and he's going to present to us a draft, some of the actions that we really need to, that will go into the final action plan. As I said, this is in a draft form, and there'll be further input to capture all the discussions that have even come up from the summer that has been done. As well, this shall be shared out to the various stakeholders just to input maybe the next 1 week or so, so that then whatever we'll be presenting and validating as the final plan will be very comprehensive. And as you said clearly, we want to ensure that this action plan can be monitored in terms of timelines, clear actions, and who's responsible for those actions. So welcome, Charles, and to take us through the draft action plan.
Thank you, Dr. Momani. I hope I'm audible enough.
Yes, you are audible, but you could just try to slightly project your voice, just slightly.
Okay. Is it fair now?
Yes.
Okay, thanks so much. I want to welcome everybody into this session. We are doing very well, and I'm so much encouraged. And like what the previous team has discussed and given the feedback, it has been a very successful discussions and deliberation that have come up from this meeting. So now we are getting to where the rubber meets the road, and I'm sure this meeting without an action plan cannot go anywhere. And I was just trying to say that maybe we talked so much, but I think we should now start seeing actions coming into place. Next. Just a quick introduction of this action plan. It's Multistakeholders Consultation Action Plan. We are saying that the Multistakeholders Action Plan is a compilation of issues and commitments by key stakeholders to give priority activities that will harness the HIV and the TB identification, diagnosis, treatment, and the community support of our pediatric and adolescent with a clear focus to achieve AIDS and the TB free children. Thank you. Next. Yes, so if you look at that diagram there, we are talking of action. Action. So this action really need to give feedback, need to give priorities. It need to come up to something, because as a government, as multi-stakeholders, we did have a lot of good plans, good strategies that we really need to put into to action. And for now, we are at a collaboration. If you look at that diagram there, and we know our objectives, and then it's just a way of improving what already we have, because whatever we have maybe come up with is not something that is new, but I think we need to change our strategies. Then of importance is how do we check? We have been talking of monitoring our actions, who check them, how do you give the feedback? And then the strategy, of course, we could not be doing the same things the same way, because if we do that, definitely we are not going to go anywhere. And then the action is very important. We really need to act, we really need to move on. And then the issue of implementation, because again, we may act, but we are not doing much. Then the issue of the schedule, the timelines. Again, we cannot just have an action plan without any schedule, without any timelines. And next. What we are seeing here is we can together as stakeholders. So all these and others, we have had so much good plans, so much good feedback, so much strategies, and you can see how they were well elaborated, the actions. So we can, as a team, so we really need to focus. We really need to focus on how we are going to manage our children, the HIV and the TB, and we can, as a team. I believe we can. Thank you. The next. What you are seeing here is this stakeholders consultation is just a compilation of commitments, because without committing, without focusing, we may not get the fruit that we are looking for. So we are saying that we need to harness the power of the partnership. We have seen that we have different strengths which we need to bring together, and in this we are going to have a very successful way of approaching the way we are going to manage our children, either in HIV or in TB. So let us look at a very robust monitoring and reporting system, because when I was listening to those slides and those presentations, I could hear that you have done quite a lot, but I don't think whatever you have done has been reported. So who reports to who? What is it reported? So we really need to come up with a very good way of reporting system, because I believe we are not starting from scratch. We are somewhere. So let's see how we can really improve on that through the partnership that we have already formed. Next. Next. Sorry. So already we have a roadmap. Again, you cannot start a journey without a roadmap. And this journey starts from a problem. Already, we have been seeing increased pediatric HIV infections, and that is the main problem. And from there, next. From there, we must act. And I'm very happy because already have started acting. And this is one of the meetings that we have already have very good deliberations. Those are the actions that we have started to undertake. Next. Then we have the responses, that is the commitment that you are going to make. Each one of the stakeholders will have the commitments, and then the outcomes will come up to solve the identification, the diagnosis, the treatment, and the community support that we have really heard about, and it has come very strongly. And then we will be winning this by having an AIDS and TB-free society. Our children will be free from the HIV and the TB issues. And if you look at that diagram, the community is coming very strongly. Yeah, and the stakeholders also, we didn't have to do much to achieve all that. Next. Yeah, I arranged my slides on the issues of the diagnosis, TB, and also on the issues of the treatment. So these have been captured, so I'm not going to spend much time on this. Those are the issues that have been captured very well, actually by Catherine in the previous presentation. But one of the things that I really want the team to pick is the issue of the stigma and the discrimination. I was just reflecting back, actually in 1981, I was in high school. I was actually finishing. I still remember we talked about stigma. So as stakeholders, that is after 30 years, I don't know what, we need to change the strategy on some of those issues so that they don't dwell on us so much. Again, there is the issue of advocacy, the issue of identification, and the testing has really come up very, very strongly. And then the issue of dissemination. So we might be having some of those very good documents. We might be having the drugs in place, but the way we disseminate, the way we put them to where they are expected to be, maybe a different ball game. So we really need to work on that. So on the TB diagnosis, those are the areas that I was able to capture. We need to involve the schools, especially on the stigma and the discrimination. Next. we have the issues of the TB treatment now. And again, the identification came up very well. We really need to work on how to early identify our children. And then supporting of multiplexing. This means we are stakeholders. We have our area that we are strong in. So we need to bring it back very well so that you can be able to leverage the efforts amongst ourselves. And then we have been having a delayed pediatric TB test results causing intervention delay. This is clear because in a community, we have not been having a very good approach on how to do those tests. So we really need to work on allowed that, and also to see how the stakeholders can support on that. Again, we cannot forget the COVID-19. It came just to affect our operations. The issue of nutrition also came up very well. Don't forget, we have had the poverty levels, they are high. So we also need to see how we can be able to support our children on the issue of malnutrition. Next. The other slide is on the HIV diagnosis. Again, I said the issue of identification also came up very clearly on our children. The issue of diagnostic, it also came up very well. Again, stigma and discrimination, as we have heard from the previous presentations, it is very strongly captured. Let's see how we can really solve that. And I think from the action that we are going to see, we are going to see the approaches, the models that we can use to capture that. Next. Lastly, on the issues on the HIV treatment, there is this commodity stockout. I think this needs to be addressed because, again, we cannot be having our patients and then we don't have the stocks in place. So we really need to capture or to resolve that issue. Then psychological support. As you are aware, many people are sick. They don't know they are sick. We really need to see how we can be able to integrate the psychology.
1, 2, 3, Mahesh, t'es là? Je ne t'entends pas, Mahesh. 1, 2, 3.
Oui, je t'entends.
Ah, ok. Alors, Spotlight, mais...
Spotlight? Ah, bon.
C'est vrai que dans le petit écran, ça se voit très mal. Pas très mal. Voilà, ok.
Non, mais ça coupe. Il y a tout qui est coupé, il n'y a pas de drapeau, il n'y a rien.
Attends, mon petit Mahesh. Alors, attends. Donc, voilà, comme ça. Après, c'est un peu plus. Là, comme ça, c'est bon, là? Non, c'est pas bon. Là, comme ça, Mahesh, attends. C'est bon, là, comme ça?
Select the new key to go live or switch to mais on a ceci de live stream là. Bon, je te laisse pas juste ça, je vais juste appeler.
Stéphane.
Ouais. Global report? No, I'm not. Good morning.
Good morning. You know the update that I haven't done on our computer?
Yes.
I have to make sure that Roman has done it before he comes.
He has to go to our office and smart desktop. Smart desktop. At there is the j'ai un petit truc là. Il dit que Duplicate stream key. Select a new stream below to go live or switch to National Multi-Stakeholder on Pediatric Day 2. Kung hindi siya. Kasi lihat siya live, pero kung sa huli na. Ouais. Ouais, je suis dans YouTube là, ouais. Comment tu vas? Ah, reset, tu veux dire, reset. This will end all your streams using this key. You will need to duplicate your streaming software with a new key to start a stream. Are you sure you want to do reset the stream, the stream key? Ouais, c'est national quelque chose là. Et ça finit à quelle heure ça? Ça fait 6 heures que ça coule.
Look, that's how she's going to look like. Is it good? I think it's
the high-level meetings the right way around.
Why is like this? Well, how do you see it?
Not easy, as we have heard from some of the presenters. So again, how well are we going to support? As an action plan, we must be able to allocate some of the activities to the relevant stakeholders so that we can be able to win in that area of the disclosure, which is not very easy, especially when it comes to the children. And then the initiative in mobilizing community through the media platforms. Actually, I'm looking forward to that time that our media platforms, our radios, our TVs should start having messages that are actually capturing on the issue of our children, especially on the TB and the HIV issues. So let's see how we can be able to support and help in terms of media platforms. Then the community management. So again, the issue of the community, let's see how well we can be able to utilize our communities in terms of TB treatment. And then the innovations I've talked about, we have so many innovations. We can even have applications, even in our mobile phones, so that you can be able to really utilize that information that is already there. Then research findings, again, it was well captured. We really need to start implementing our research findings because we might have so much, but it's not well utilized. It's not, nobody is actually implementing. So the stakeholders should come up really well so that they can be able to support us in terms of those findings. Next.
Charles, just a gentle note that you have about 3 minutes left.
Yes. Thank you. Then we have the HIV diagnosis. Again, I was saying we need to improve the access. It was well captured. Again, the issue of the stigma came up very well. The issue of adopting the innovations, they also came up very well. Next. HIV treatment, the key actions that we are going to plan for, again, is the early identification. The issue of the phase-based actors, it also came up very well. And for these phase-based, it's a very important intervention. And again, the previous presenter, Catherine, mentioned about how we can leverage the effort that is given by the phase-based actors. Next. Amidst all these efforts that we have, I'm going to capture the risks that are going to be there. Of course, you know, there are many risks that we can go through. We already have started seeing the risks of political political, the financial risks, and there is a corruption risk that we don't have to forget about. So I'm going to capture how each of these activities, how it can have a risk, so that you can be able to go around those risks. Next. I have a table that is actually the important thing. You can open that table. Yeah, thank you. So this is the key item that we have in this meeting. So this table is the one that is going to show the commitment for each stakeholder. So for this particular presentation, we are able to group our stakeholders into 10 groups. So we have the international NGOs that we have been having in this meeting. Then we have the national NGOs. You can just scroll down. Then you have the Ministry of Health. Just keep on going down. Then you have the CBOs at the communities. Keep on moving down. Then you have the NAC, the face sector, NASCOP, and then the National Tuberculosis and the
password, Zoom, the password of Miguel. There you go. Your laptop. So sign in. Okay, we are here. We are at your disposal. Okay, so I'm going to start the meeting. So it's New York time. I put for 10 hours, okay? Okay. 10 hours. What time is it? 9? Yeah, it should go. No problem. Why am I not hearing anything?
maybe just host, if you can unmute Mariam, just to give us her reflections. Is Mariam Garuri there? Well, Mariam says, Charles mentioned on the start, we don't know who reports where. We need to streamline information sharing. Something that did not come out clearly was empowerment. Sorry, I've lost that. And I've lost her chat. But I think Mariam's point was the issue of really in the accountability framework, just clearly outlining how information sharing will happen from the community level all the way up, I think is something that we really need to incorporate. And she also talks about economic empowerment interventions, especially for caregivers. And that's, I think, even from the beginning of the meeting, we had indicated that something around social protection must be incorporated in this action plan. So thank you for that, Mariam. JASEC has recognized that Global Fund is missing, and that is noted, well noted, JASEC, and that will be incorporated as a key partner and responder to issues of pediatric TB and HIV. So if I think we can just look at, let me just look at out for any hands up. If you have any reactions to the action.
Yeah, I'm looking to the chats. I've just seen from Medine just saying that she appreciates the responsibility matrix. And then the others just saying that they look forward to the finalization of the action plan and the presentation of the final action plan to the stakeholders. Yeah, so we don't have any, there are no more hands from the chats, Teresa.
Okay, so in that case, then allow me just to, again, just reiterate that this is work that it's been like 1.5 days rich discussion.
Teresa, just a minute, there's Peter Whitty. Peter Whitty, would you like to say something?
Yes, just on the issue, I believe we may be having the county government representatives here, and there are issues that really happens at the county in terms of information sharing and linkage and coordination, particularly with community level actors. So I don't know how we'll incorporate that, but I think there is need for that kind of coordination to be streamlined right from the NTP and right to the grassroots, where we are acting as partners, we are all contributing and cycling the wheel of eliminating TB. Thank you.
Thank you for that.
Yeah, there's also Stephen Anguva. Please go ahead, Stephen. Maybe you can, Edwin, you can unmute him.
Yeah, thank you. I'd like to thank the organizers very much for this presentation. However, one thing that I want to bring to the attention is that, yes, we are delving into engaging children as our new advocates in terms of pediatric TB as well as pediatric HIV. I think when we are engaging them moving forward, we should also look at respecting their rights, because many a times that we engage children, maybe like a one-off engagement, then we leave them behind. I think moving forward, when we're engaging children, we should move with them because we don't leave them behind. If you look at previous years, you've seen somebody like a child has shared the experience. Then after that, 5 years down the line, the child is not even seen or there's no follow-up action. I think now moving forward, when we engage advocates and we want children to be champions, let's walk with them through this journey up to the level that they become adults.
Thank you so much, Stephen. I think your sentiments and your input is well appreciated, and just on how we work with the children, even as we try to resolve some of the issues. I'm also seeing Shadrach Mahonga. Maybe we can have that as the last comment for the interest of time. Yes, Shadrach.
Yeah, you can hear me?
Yes.
You can hear me, yes, huh?
Yeah.
Yeah, I just wanted to follow up on what Peter has mentioned, because in our action plan, actually, we have pointed out the need to involve the community systems at the grassroots, that is the CHVs and the CHAS. That one has come out very strongly. But I just want to reiterate that when we are doing that, please, the how should actually come out very clearly in our action plan, so that we know what we want to do, we want to involve them, but the how actually should come out very strongly, so that it is very clear in the counties what needs to be done in involving the community services. Thank you.
Thank you so much, Shadrach. I think that's well noted that the action plan needs to break down the actions to the last implementable bits, so that it's very clear in terms of the how. For example, when you say engage the communities, then how will that be done? So I think that's well taken, and the team that shall be finalizing on the work on the action plan needs to take that into account. I see a few charts, I think from about someone asking, what is your take on HIV/AIDS support in so-called low burden areas or counties? I think that's a very pertinent question to ensure that, even if it's just 5 children in those counties, then they still need to be taken care of. I think that's a good comment, or a question you're posing to the team, as well as someone is also asking, we need to work together towards a child. I think that's a comment. There's someone saying there was a question in the live stream from Patrick Oyar on how best can we engage the private sector in the fight against TB. And I think that is also something that probably we can reflect on in terms of engagement of the private sector. I know from NASCOP, currently we are working on a framework that is going to really bring in the private sector. Because we know that a good proportion of patients or people are being seen in these private facilities, and also there's a key role they can play. So I think that we shall see how to bring that also, just to ensure that the private sector is not left behind. But it will also be just interesting to hear from the TB side how this is being done. So at this point, I want to welcome Teresa to just give us in terms of next steps, in terms of this action plan, what's going to happen, Teresa?
Okay, thank you. Please confirm that you can see my screen and hear me.
Yes, we can see the screen, though I think it's probably it's just the view. It looks like it's part of it is not being seen. Maybe you can put slide mode.
Okay, let me just put it on slide mode and share it. Oh dear. Do you see it now?
Now, Teresa, it's clear. It's clear now.
Okay. All right, thank you. So, just as suggested, we want to thank Charles for the comprehensive action plan that an outline of the action plan that we are going to see. And like we said, this is still work in progress, and we will need your help as stakeholders to finalize this action plan. So we are going to start a process of compiling the meeting feedback and resolutions, and this will provide a segue just for us to put everything together as has been discussed and suggested in this meeting, and it will be sent out to you as stakeholders and to your networks by the 9th of June 2021. During that week, we will request of you to collate feedback and send it back to the Secretariat team between the 9th and the 16th. And by the 16th, we should have gotten all the feedback from the relevant stakeholders. So here is where we would really want you to even share out to those who are not able to attend this meeting. Finalization of this action plan will be done the week of 16th to 24th June, and we will expect to have a validation on a date to be determined between the 25th and 30th of June. So by the end of this month, we really want to have a solid action-oriented plan that will pave way for our action and our resolutions for pediatric HIV and TB. So this marks the end of this session on the action planning and just having a review and reflection on what the action plan will look like. And I'd like to hand over to my co-moderator, Lazarus, to take us through the final steps of this meeting. Over and thanks.
Thank you so much, Teresa, for taking us through in terms of the next steps. We shall work very closely, the Secretariat and the team from NASCOP, the team from the National TB Program, NAC, and UNAIDS and the other partners to ensure that we commit to those timelines and look forward to the action plan the final action plan being launched or being shared, as well as really getting to the work itself, which is really implementing the actions. So thank you so much. And I think it's been a very fruitful two-day meeting, very active discussions, engagements, free sharing of information and suggestions. I really want to thank everyone who has been part of this meeting. And we also really want to appreciate you for getting engaged for the 2 days. It's very hard, I know, being in a virtual meeting for 2 non-stop days, but you've been able to do it and having very good participation. So at this point, I want to move the session to the closing remarks. But before we have the closing remarks from the government, I would like to invite Reverend Jane Nganga to just give some quick remarks on behalf of the faith-based organizations. Reverend Jane Nganga, karibu sana.
Asante sana. Thank you so much. And I want to join you and the rest to say how grateful we are for this process and specifically for the leadership that we have had from NASCOP. Thank you, Dr. Catherine Goge, and also from NAC, Dr. Ruth Masha and the entire teams for the support that you have accorded in this process. And as we come to this end of this rewarding multi-stakeholder consultation, which has been very, very inspiring, we are grateful even as a faith community that initially was at the forefront in terms of planning and also engaging with the others to see that this process is successful. And looking at the outcomes that we have had in terms of the drafts we have for the action plan and even the initial reports, we can see the vigor that is there in terms of engagement and the strength that comes when we work together and when we engage all in a process. And we look forward to the same vigor in ensuring that we go to the implementation stage. And on behalf of the faith communities and the communities at large, I sincerely want to thank all for the perspectives that have come across and for what we have, the insights that we have given that will ensure that we have the enjoyment of the fundamental rights by our children. And specifically, I sincerely want to thank the communities for engaging, for the women, perspectives we got from the women living with HIV and caring for children who are living with HIV and TB. I sincerely want to thank you for the perspectives we got from the adolescents and young people and also from other communities that are providing services, and specifically also perspectives that we got from the faith communities who are providing or delivering services, and also congregations that are involved in the response in HIV, pediatric HIV and TB. And we know the place of the faith communities and the strength they hold and the passion that there is, and also the reach that faith communities have. And this is something we can utilize, or this is a platform that we can utilize to ensure that we are sending out messaging, to also ensure that we are constantly engaging with even the children, the parents, and the caregivers of the children that we are reaching out to. And as faith community, we do commit to continue engaging with the various faith community platforms to address the pediatric HIV and TB issues, and also to see that the actions that we have come up with and those which are specific to faith communities from these consultations are realized. But even as we commit ourselves, we also, as we thank the government through the Ministry of Health for taking the lead, we want to call also on the government and also the political leaders and also our communities to ensure that we fulfill their obligation to do all they can to protect the health of all children, and of course also adolescents, including those who are living with HIV and TB. And we specifically call out to key partners, communities, and also government in this consultation to ensure that the issues that we have discussed are well taken care of, but more specifically to ensure strong commitment to successful integration of services, ensuring stronger coordination among health programs by promoting the adoption of innovation that support strengthening of linkages, including offering incentives for joint planning and integration of services across relevant Ministry of Health departments, as well as also including the faith-based facilities. We also call upon also the government to ensure that there is identification and treating of undiagnosed older children, including adolescents, and providing all children and adolescents living with HIV with a continuum of appropriate care and social protection proven to improve health and psychosocial outcomes as they grow and progress through youth and into adulthood. And this is one of also the issues that came across, that we have so many adolescents who are having children, but a lot of times they go undiagnosed, and therefore we hope that this will be taken up as we go by. And we also, as we invest in adequate training for healthcare workers in pediatric HIV prevention, testing, treatment, care, and support, we also calling upon the government to include those within faith settings. Let them be part of the training so that they are able to also provide services as required. And as we recognize and support the role played by faith community volunteers in sharing appropriate information about HIV testing and treatment of children, as well as advancing family index testing and supporting retention of children in care. So we need to recognize that role that faith community volunteers also play and ensure that they are equally supported so that they are able to provide the services as well as the other volunteers are doing. And finally, we also call for consistent supply of palatable HIV and TB treatment for our children, and of course for all people living with HIV. The consistency in supply is very, very important so that we ensure that we do not have stockouts as we have seen recently. And this is our plea, and as we also commit ourselves as the faith community to ensure that we are also supporting this process. So it's been a great process, and we thank all, and may God bless us. And as we go about now the implementation, we pray that God will see us through and that we will be successful in ensuring that our children are well taken care of. Thank you so much for the opportunity, and over.
Thank you so much, Reverend Nganga, for those kind words and just highlighting how the faith-based really are going to commit and support the initiatives that you have put in place. So at this point, I want to welcome the head of NASCOP, Dr. Kate Ngugi, to give us closing remarks and also close the meeting.
Thank you, Dr. Momanyi, and thank you all the speakers who have made the meeting for the last 2 days be a very, very successful meeting. Honestly, listening to each one of us who has presented since morning yesterday till today, we have noted that the solutions are with us. We have the solutions. So it's just for us now to sit down and action the different interventions, be able to scale up, intensify and scale up the promising interventions, innovations towards the prevention care treatment, especially of HIV and TB in our children. We have noted from here that we have identified, say, very effective and strategic partnerships and collaborations. We have been able to highlight the gaps and solutions. We have been able to better understand the situations and specific challenges. The breakout rooms have really a good running point for each one of us, especially the community-led response, service delivery, innovations, and leadership and governance. I really want to take this opportunity to appreciate each one of you for the time that you have taken to ensure that we can be able to step back, reflect, and see where did we miss the step, and how do we go back and ensure that we are able to address the many gaps of where we lost the step. I have areas, and I know they were highlighted in the action plan, but thank you, Dr. Teresa, that it's going to be refined. So as we can have a more refined action plan. And thank you, Mr. Charles. But however, I note like NASCOP has only 2 action areas, but I think even the counties, and I see Global Fund as well was missing from there, that maybe we need to define it, and I hope there'll be a team to be able to revise that. We have taken some of the gaps, for example, in community response that we are really not doing well as a country in psychosocial support. We need to strengthen the community involvement. And in fact, the role of the community is not really well thought out and well implemented. Yes, in paper it may be there, but really in action, we really need to put it into practice. And we have had intimate sharing of our PLHIV telling us what they go through. Availability of commodities, and definitely as we discussed and as I highlighted yesterday morning, the need for us to secure the commodities for our children. I'm really grateful that for the last 1 week and a half, we have negotiated with the PEPFAR and some of the commodities that they are to bring. And so far they have committed to procure DTG-10 of the 90s pack of around 48,000. And there were 25,000 that we are receiving from Chai, and the government will be allocating as well as more. If we get these commodities at least soonest, but I know as well as supplier is really trying as much as possible to meet the demand of the different countries, then by next year, we'll be able to transition our children, all of them. We note as well issues to do with data access, and we promise to be able to, we will share it, and so as we can ensure that you keep the government, both nation and county, accountable to it. We note as well the integration of TB and HIV, especially on children, the several innovations, the need for the 67 POC EID, ensuring that not just machines in the counties, but ensure that the counties take up the cost for sustainability. So for the 390s, definitely we need to address them. I take this opportunity to appreciate Dr. Medine for her technical and financial support with the United Nations family. Please pass our regards to the UN family for the really support that they have really accorded the government to have a very successful meeting. As well as Dr. Tamu, please Maxwell pass our regards to the PEPFAR and its agencies for the support you keep offering Kenya over the years, because all the gains that you have made, it would not have been possible without you. Thank you, Dr. Marsha and your team for ensuring that we are able to have an area that, an institution that we can have stakeholders be able to be coordinated from one area. Dr. Mbai B. Sinsi of the chair of the caucus, Mr. Ochero for the Global Fund. Honestly, we know as well, if it wasn't for Global Fund, the many achievements we have made for the last 2, 3, 4 decades, it would not have really been possible. Thank you, NAC, NASCOP, United Nations Family Team, TB Team, People Living HIV Networks, the communities, civil society organizations, faith-based organizations, implementing partners, especially EGPAF, ACTB, CHAI, UNITAID, INERERA, for really making and gracing this occasion and making it successful. We really would as well assure you that this meeting will be biannual, meaning that the next meeting will be in November, the first week of November, and really requesting the UN family and PEPFAR, the way they have technically and financially supported us, to ensure that we have another meeting. So as the actions that we have put in paper, then ensure that we can be able to be held accountable for it. In my remarks, you noted yesterday, I said today and yesterday, the commitments we make, all of us shall be held accountable. So really looking forward to all of us meeting in November, but going to action now on the areas that we need to do. And we request you and family to finalize on that action plan so as we can share with the different stakeholders. Thank you, faith-based organization, and extra thank you for spearheading and for speaking for the voiceless, especially our children. For the many participants who have participated, being able to pay even their own bundles, we really appreciate. And we reaffirm our commitment to ensure that children within the next 1 year, 2 years, in fact, 1 year maximum, we should have virus suppression that is more than 90. We should identify them. And especially I'm glad when PEPFAR committed on the community-led responses and community involvement. We'll do that. Thank you all. Have a good evening. And the meeting stands closed. Kwaheri.
Thank you so much, Dr. Kate, for the remarks. And at this point, for closing, being available to the meeting to even close the meeting. So at this point, I'll welcome Kristen Njogu to give a quick vote of thanks and to recognize some of the people who worked behind to make this meeting a success. As then, after that, we shall have prayers from Reverend Nganga, and the meeting shall be closed. Kristen?
Thank you, and thank you everyone for us having been here for the 2 days. Allow me to just make a few comments that we've made commitments as stakeholders to do better, to change the current HIV and TB situation of our children. And my prayer is that these commitments will not remain on paper, but will actually translate them into action. And that if we each do our part and remain accountable for results, then we will be able to see a change. My appreciation to the participants for the 2 days. I also want to appreciate the planning team. We've had a work since April, and specifically, I would want to appreciate the communities. We had Maureen Murenga, Evelyn Kibuchi, Cindy Amaiza, Jackie Wamboi. We also had representation in the planning team from the Faith Sector Working Group. And from the faith sector as a whole, we had Reverend Jane Nganga, Zilpha Samoei, John Okero, we had Miriam Mwangi, Charles Kibara, Jacinta Mutegi from KCCB, Catherine Deuri, and Peter Morioki. From the UN family, much appreciation to Ludfin Bunde, Edwin Opora, Teresa Aroa, Dorcas Abuya, Jane Kamau, Yasek, UNH Geneva with your colleague team, and Ridia. We also had support from the Faith Initiative under the PEPFAR and UNAIDS, specifically Julien Munyaneza and Francisca Merico. We also had partners, Maxwell from PEPFAR, Manoj Kurian from WCC, and Janet Mwema from CHAI. Not to forget my colleagues in the government, Wangoi Muthigani, Francis Ndwiga, Winnie Nyanya, Lazarus Momanyi, Maureen Inima, Jane Mokami, Jackie Kisia, Philip Owiti, Violet Oramisi, Mike Ekisa, and if there's anyone else that I have forgotten, much appreciation. We also would like to appreciate the support and leadership from Dr. Medine, Dr. Masha, Dr. Catherine Ngogi, Dr. Wako, Mr. Joseph Mbai, the chair of the CC caucus, and much appreciation to all the moderators and rapporteurs, and also a lot of appreciation to PEPFAR and UNAIDS. Through the Faith Initiative, this consultation would not have happened without their support. May the Lord bless us all, as we also pray that we will be back here again to review the progress made in the commitments. So thank you very much and be blessed. Thank you. Back to you.
All right, so thank you so much, Christine, for the vote of thanks. And I didn't hear you appreciate the sign language interpreters.
Oh, yes, yes. My
Yes.
apologies. Yes, much appreciation to our sign language interpreters. We really do appreciate you as well. We also
Thank you.
appreciate everyone who has really been here for the good of our children. Be all blessed.
Yes, and the IT team that has been working behind the scenes, thank you so much for that. So before we have the prayer from Reverend Jane Nganga, we'd like to, IT Edwin, please play the child's prayer video if you have it.
Hi, my name is Michelle. Let's pray that God will give us the deliverance and protection during these COVID times. Our Father and our God, we come before you this day, thanksgiving in our hearts. We thank you for your guidance and your protection. We thank you that, Father, you have been with us through these hard times. Father, we even pray for those people affected by COVID-19. We pray that, Father, you shall deliver them, that, Father, you shall give them the resources needed to be able to fight this disease. Father, we even pray for those people infected. We pray that, Father, you shall heal them. You shall stretch your hand of healing upon them. Father, we even bring the doctors into your hand. We pray that, Father, you shall help them to find a vaccine to be able to fight this disease. That, Father, you shall give them the wisdom and understanding. We even bring the world into your hands. We pray that, Father, you shall deliver us from all evil. We pray that, Father, we shall have peace in the world. That, Father, we may not have any evil doings during this time of our lives. Father, all this we give you glory and thanks. Father, thank you for everything that you've done for us. We don't take it for granted. We pray that, Father, you shall continue to be with us and bless us. All this we pray, trusting and believing. Amen.
Amen. Amen. Amen. May Reverend Jane Nganga please now give us the final prayer.
Okay.
And after that, the members can be able to log out at their own pleasure.
Okay. Let us pray. Dear God, we come before you this evening with grateful hearts. We want to thank you for being with us throughout this planning process for this national consultation. We thank you, Lord, even for making it a success, for bringing us together, and for everything that we have discussed regarding our children. We return all the praises and all the glory to you. It is by your grace that we have been able to manage this meeting. We give you honor and we give you all the glory. Lord, we are grateful because of the actions that we have put across, oh God. It is our prayer that you will give us the strength and the grace to realize them to the glory and honor of your name. We know you care about children and you have a very special place for children, oh God, in your heart. We pray that the same heart, God, you will give us, oh God, that we will not tire until, Lord, we see that our children, especially those who are living with HIV and TB, get drugs and are able to be diagnosed at the right time, that they are able to live quality lives, oh God. We pray that you may help us as a nation, oh God Almighty. We pray for the policy makers that, God, they will prioritize children in everything that they do, oh God. And we pray even for the ones who are providing services, oh God. May you give them the grace and the strength and the commitment to be able to support our children. We commit all those who are right now affected with TB and HIV. May you give them the grace, oh God, as they take their drugs, oh God. We ask that you will bring a turnaround in their lives, and even Jehovah, Father, strengthen them and give them, even Jehovah, the courage to face life, oh God. We thank you and we bless you. We pray that you will bless us even as we depart this afternoon, that God, every person that participated in this meeting will leave it with your blessing and with such a passion to see a turnaround in our children. We give you praise and honor. We give you thanks. We pray all this believing and trusting in Jesus' name. Amen.
Amen.
God bless you. Thank you so much.
Man, when we think about the suffering in ghetto, we feel bien, child. Yes, when we turn to pediatric AIDS treatment in Africa, man, call them bata. They make black man so proud, man.
Yeah, your people. Well, this song is dedicated to the children of Africa. We're here to say that no child should be born with HIV in Africa. And if you believe with me, rise on your feet and let's sing together. Yo, 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 yo. Children infected with HIV, some are orphaned and they don't know what to do. Who will fight for the right? Who will really care about them? That's why we sing Pata, we care for the children. Whoa, whoa. Whoa, yeah, 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 yeah. Yeah, 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 yeah. Africa we see, Kenya we shout, Tanzania, Mali, Ivory Coast, South Africa, Swaziland.